So welcome everyone. I'm Dr. Rajvee Vora, the Vice Chair of Clinical Affairs for the Mount Sinai Hospital for the Department of Psychiatry. It's my pleasure to introduce everyone on this panel today and to kick off the symposium. The idea for the symposium started when we started dealing with a very highly complex group of patients on our inpatient floors. And we kind of started dealing with these challenges and, through COVID, which most of us have sort of been through in the last couple of years and noted in our own areas, the intensity of the patients that we are treating has definitely gotten more severe. The lack of resources on the outpatient side, the difficulty in discharging some of these patients was really, really, great in the last couple of years. Through this, we actually had a very difficult patient that we had been struggling with in trying to manage him on the floor, as well as trying to find a discharge plan. And Dr. Rosenthal, who is our unit chief for Madison 5, one of our inpatient units at Mount Sinai Hospital, came up with this idea that it would be so amazing if we could find a way to share some of these challenges and come up with solutions and maybe strategies on how we can deal with some of these patients. And we sort of started working on this together with our Director of Inpatient Services, Dr. Jan Schutzmiller. And we started to put together a program that we thought would be helpful to the people on the front lines, the residents, the trainees, the social work staff, the nursing staff, as well as the physicians, of course. And how do we manage some of these very challenging cases? People with developmental disabilities that end up on psychiatric floors, and we have nowhere to send them, discharge them, manage them, because again, we don't have some of the behavioral tools. Patients with very complex psychopharmacological issues that we've done everything we can, and we can't seem to find a way to, control the symptoms. As well as patients that have very significant histories of suicidality, violence, as well as personality disorders. So we worked together to find this expert panel, and I'm very proud to introduce all of them to you today. I really hope that today's symposium is going to help in managing some of the day-to-day challenges that all of us would face. And we get something out of it at the end of the day. I really want to thank the panelists because some of them are even taking time out of their vacations to be with us today. And this, this whole thing took a while to put together. We've been talking for almost 6 to 8 months, and I really thank them for their patience and being available today. Without further ado, I think we should kick it off. I'll have Dr. Schutzmiller introduce Dr. Charlotte, who is our first speaker for today.
All right, good morning, everybody. So I am Jan Schutzmiller. I'm Director of the Inpatient Service here at Mount Sinai. I'm going to introduce the first panelist, Dr. Charlotte. But before I do the full introduction, I just want to remind everybody that we'll have a Q&A session after the talk. So if you have any questions, put them into the Q&A function or into the chat, and then we'll have a chance to get to them at the end of the talk. So Dr. Charlotte is a developmental psychologist. She earned her PhD at Boston College. She's been working for over 30 years with individuals with autism and other intellectual and developmental disabilities, specializing in comorbid psychiatric disorders and challenging behaviors, such as Dr. Vora just mentioned. She's an assistant professor of psychiatry at the UMass Medical School, where she designed and directed a 10-bed inpatient psychiatric unit for people with ASD and IDD. She's published original research and lectured widely on the care of these individuals across the US and Canada and Europe. Dr. Charlotte is an author on multiple chapters in the DMID2, which is the IDD version of the DSM. She also did crisis outreach to people with ASD and IDD who were treated on non-specialty psychiatric units and in emergency departments. She's published research regarding medical comorbidities among psychiatric inpatients with IDD, and she runs a special multidisciplinary evaluation team for this population as well, and has worked as a federal court monitor. She's recently been working closely with the NYC START team, which is a program that specializes in helping individuals with IDD and ASD. All right, so I will hand it over to you, Dr. Charlotte. Welcome, and thank you for participating.
Thank you so much for asking. Just gonna load my slides here. Can you see everything okay? Great. So again, I'm really grateful to be invited because as much as you're struggling with how do you care for these patients with really unusual presentations, I'm always struggling to translate things about these people when they get into settings like yours. When I get the opportunity, and I don't always get asked that often, so I'm grateful to be asked. So I'm older, so I remember this book that I read many years ago, and some of you may know it, and even younger people know it too. It's called The House of God. I show you here on the slide a few examples from The House of God. And one of the cool things is this is a resident in the Boston area at a special hospital there. And he just described all these difficulties in working with patients who for him at the time were people who had really specialized kinds of difficulties. Any case, I said, well, I've only got 45 minutes to tell you about a pretty complex population. So I'm going to have my top 10, the way there were the 10 laws of the House of God. I'll have mine for the House of UMass. And I'm going to use, a lot of examples from my work that was on the specialty inpatient unit. So we're going to go through these one at a time. And the first thing that, occurred to me when people were asking me about doing this talk is that I learned a long time ago that these challenging behaviors that require management, where we really have to, be on our toes, people engaging in aggressive behavior. Throughout the talk, I'm probably going to say aggression, etc. But by that, I mean, people yelling, screaming, meltdowns, breaking things, running out the door when they live in group homes, etc. It's that whole kind of package. That these things occur less when we could get the treatment right and it was effective. And so the big focus I began to have, why I worked on that DMID project, is helping people get the diagnosis and case formulation right. And I also did a lot of writing behavior plans and other sort of things like that too. But a big lesson I learned was from a comrade of mine from the Boston Children's Hospital, who did work in one of the settings I was in early on in my career. And he ended up saying, aggression and all those challenging behavior things, they're like a final common pathway for distress in this population. And this is a population where even the people who have lots of words and allegedly have very mild intellectual disability, that, that they don't have a very large repertoire or language sophisticated enough to tell you a lot about internal states or to give you a reliable history. And so what you end up seeing is that stress gets manifested in challenging behaviors. It's not diagnostically specific. I get worried that people get in a tangle when they're and they have to be very concerned about the aggression that's presenting, but they're not really looking at other factors that may be the key to reducing the risk that the patient has. The other important thing is that the same set of symptoms and this, what people often refer to as mood dysregulation and challenging behaviors, they can be occurring 1 week for one reason and next week for another reason. Why my colleague used to say it's like a fever. So you go to your primary care and you have a fever, and you might have it for many different reasons and many different pathways. And for good effect, you got to look at the pathway. So I'm using some case examples. Jerry was a 32-year-old man with autism, and he was admitted to our unit. Almost all the people who came to my unit were there because of aggression, because we were this 10-bed specialty unit, and many of them were referred for that reason. But on top of that, a big issue that was going on along with the aggression is that he was not showering. And so he had not showered for weeks when he came to us. He was being treated for bipolar disorder. But when we looked back at his history, this often happens, he really didn't have a clinical course in history for bipolar illness. A lot of what he was doing, he did when he was just very young, very little, just more or less from the get-go, but now he was larger and more intimidating to people and more dangerous when he got aggressive. But in any case, my staff, Dave, gave him cookies and milk when he arrived on our unit, and he put, some, very, very nice things in his room and got him unpacked and settled him down. And then a little later, he came in and put this guy's clothes out. He told me he put them out on the bed, and he turned the shower on, and he didn't say a word, and he left. And then this guy took a shower for the first time in weeks. And it was very interesting, all of the work that he did to be kind and gentle and show this guy that, we care about you, we're going to help you. He did that extremely well. And then he didn't place a demand on this guy. He didn't even say it in words. He just turned on the cues and it worked. The other kind of case example that I was going to give, it's a little embarrassing, but I did used to sing and dance with my patients on my inpatient unit periodically. It was called for. Not everyone enjoyed it. Fred, who had epilepsy and mild intellectual disability, he had serious aggressive outbursts that would happen right before he had a generalized tonic-clonic seizure. And you could know he would have the seizure, then he would, his mood would improve, he would be somewhat calmer, then things would build up, then he'd have a big blowout, and then he'd have a big seizure, a generalized tonic-clonic seizure. On this particular instance, he was leaning over the half door at our nurses' station, and he was escalating rapidly, and people were kind of backing off and not really sure what to do because he was right in the middle of everything. I was able to get him to walk down the hall with me back to his room and to rest and listen to some music, but I got him there by singing Yellow Brick Road, because I learned when he came into the unit that he was a huge fan of that music, and it won him over. He knew that I was on his side and he relaxed a little bit. So I think it's like worth taking the time, whatever you can do, to get to know these folks, and on that more kind of personal level, and especially showing them, because they don't trust the universe, that you're there and that you care about them. And it sounds kind of trite, but it's a really important thing to try and do. And then also to know them in regards to their neurodevelopmental profile. So labels like mild ID, moderate ID are somewhat helpful, and you can sometimes find a full-scale IQ, but it's not as helpful as you think. Often folks, even with mild ID, they know a lot of words and scripts, and they kind of learned what to say in various situations, but they don't have great problem solving or information processing skills. So we tend to, and group home staff often, and family members even, will overestimate someone's capacity, expect a little bit too much from them, and that in itself causes challenging behaviors that wouldn't otherwise occur. So when I'm looking at full-scale IQ, I want to look down in that testing report, and I want to see if somebody got huge variability between the subtests in their testing scores. Is there a much higher verbal or performance area score? Are those scores similar? And the FSIQ looks like it's fairly high, and then suddenly we have really low working memory abilities or processing speed. Another area is social cognition or social awareness. A lot of people we work with have autism, spectrum disorder, autism, and they may have a pretty high IQ. I have a nephew who has this, and so I've learned both professionally and personally. And he has a high IQ, but his social awareness and understanding is very impaired. And he's very much meets criteria for an autistic disorder, but it wasn't found till he was older, because people missed the fact that he had the autism because he was very smart. But socially, he was very challenged. Many people, even as I said, with mild ID, will lack social awareness. They'll look like they're oppositional, non-compliant. My nephew got labeled as conduct disordered, and he wasn't. And eventually discovered really a lot of his challenges had to do with his neurodevelopmental profile and what that was causing him to display when he got stressed out. So to diagnose mental illness correctly and to prevent or respond to these outbursts and challenges, you really have to understand the person's profile in these various domains. If you can get hold of that kind of information, it's really, really important. We talk a lot in my field about executive functions. So much of the research on executive functions, in my experience, has shown that IQ is disconnected from some of these capacities. So again, leads us to think people are going to be more capable than they are. And we do a lot of helping them through talking to them in ways that they may not fully understand, and they won't tell you that they don't understand it. So we have issues, as I mentioned, processing speed and working memory. But one of the big areas in executive function or frontal lobe functions that can be off is this area of mental flexibility and set shifting. So it's the fact that I can sit with you one-on-one, I can tell you what my new coping strategies will be, but then I get stressed and I can't access that information. I can't shift. And there's a lot of perseveration and problems that occur because we're trying to get somebody to shift gears with new information, and they have great difficulty doing it. And this, like many of the other things I'm discussing, they add risk for the management concerns that you're worried about. So I'm a developmental psychologist, so I think developmentally. And people get confused. I'm not suggesting that you treat adults like they're children. That's not at all what I'm saying. What I'm saying is that we sort of, most of us understand the development of cognitive capacities and emotional and social capacities in neurotypical development in children without disability. And we can use that as our reference when we're trying to understand what happens when there's a developmental challenge to somebody's information processing and executive skills and all these kinds of things, that they may in fact understand or perceive the world or respond in ways that are like younger children, even though they're adults. And it's an important thing to understand, because psychopathology, as we do a differential diagnostic workup or thinking, what's a departure from usual behavior? I remember learning about this with cultural influences. People from different cultures will respond very differently to stress and to different situations, and it not necessarily being that represents an acute psychiatric problem. It might be from your culture, you tend to react in certain ways. And this is very true in the importance of understanding developmental influences on people that we're talking about in the special population with ID and autism. How are they going to respond? So two case examples I often refer to are people that I've worked with and been with a great deal. And as you can see on the slide, case one and case two had the same example. They went to a theme park, believed the characters were real, very much believed they were real, really into that extensively. Then it came time to leave, both refused, lots of coaxing and pleading. So case number one is my daughter, Nicole, when she was about 4.5, at the Magic Kingdom, where I learned that you can have too much fun at the Magic Kingdom. And I basically literally carried her out. Case number two, however, was David. David was much older. He had autism, moderate ID. He eventually got on the bus with offers of something special for him, but it took a while and he was very agitated. If he'd been in a different circumstance, he might have been given an IM, for example. But we were able to convince him that we wanted his cooperation in a much more successful manner. So back to this topic, wrong psychiatric diagnosis is a large cause of poor outcomes. People with autism and intellectual disabilities, they can have most any psychiatric disorder. I'm sure most of you are aware of that. They have higher rates and higher risk factors. But in the really well-controlled studies where they're population-based and not a convenience sample, and they're done really with people who understand, who have expertise in the population. United Kingdom is one of the better places that I've seen studies from, because they have this unusual thing called national health care. And so they have specialists in ID and autism in the field of psychiatry, and they tend to report somewhere more closer to 30 or 40%, but some studies will say 70% or 80% of people. Aggression is the most common reason, as I mentioned, that you get called into a mental health situation where you're referred for services and care. And it can be provoked by the different various psychiatric disorders, by many other things that I want to cover to help you sort of get to the bottom of what's going on when you're trying to help people. I just have to remind people that the most common to least common psychiatric diagnoses aren't always what you think if you're on an inpatient unit taking care of folks, but it's really anxiety and depression. And I had many people on my inpatient unit who were aggressive enough and in need of inpatient care when their primary psychiatric challenge was anxiety, because that can happen. People with trauma, often become anxious, and they may become depressed, and people with ID and autism have very, very, very high rates of being exposed to trauma. The bipolar disorder and psychosis labels happen, I think, way too much. And it kind of reminds me of childhood pediatric bipolar disorder diagnoses. I knew someone in the Boston area kind of promulgated a lot of excitement about diagnosing that in children, but changing the diagnostic criteria. And that's, I think we've kind of passed that situation now, but it's happening with people with ID and autism. And the problem is when it does happen, and it does, it's very, very severe, both psychotic disorders of various kinds and bipolar disorder, but it gets overdiagnosed, and then people get down the wrong pathway and have difficulties and don't get well easily. ADHD is common in kids, especially with autism, but sometimes they really don't have ADHD and it just looks like they do. And then again, you get down the wrong pathway. So in any case, anxiety, agitation, and aggression, very, very common. The most frequent driver of this mood dysregulation, anxieties, even sleep problems, all these sort of things is anxiety. And I love the law from the house of God, at a cardiac arrest, the first procedure you do is take your own pulse. And in a crisis with a very large, very aggravated, potentially violent person with autism, that could be a helpful thing to do as well. Anyhow, approach is everything. Ask, the person, can I help you? Are you okay? You approach people calmly and quietly, even if they're pretty agitated. I'm pretty good at doing that. I learned how to do it over the years, and trying not to show anybody that you're afraid, because it makes them afraid, and then there's more aggression. Conveying support, providing reassurances, telling people they're safe. When there's trauma, they just want to know it's okay. Sometimes you have to say you're going to handle it when you know they can't. And then to consider panic-driven, agitated, aggressive behavior was some of the most dangerous that I saw in my unit. We're about to publish a paper, I hope. Manuscript has been submitted for publication, where we looked at 50 of our consecutive individual patients who had ID or autism referred to my multidisciplinary team. They only could get referred to my team if they weren't responding to their usual psychiatric and mental health and behavioral treatment care in the community. And just quickly wanted to say that we found, as I mentioned, an overdiagnosis of bipolar disorder and psychosis, and an underappreciation of anxiety. And again, this is really important because we're going to use a really different approach. It's not that bipolar disorder and psychosis don't happen. It's just that when people aren't responding to their treatment and they have ID or autism, one of the things to do is say, have we got the diagnosis right here? Number 6 of my top 10 list is to think about the medical comorbidities that also drive agitated behavior. And probably some of the most remarkable things in my career, especially on the inpatient unit, was discovering, these medical comorbidities and then seeing people's mood and behavior improve in ways that people previously thought were all due to a psychiatric thing. So I just gave you a list that this wonderful primary care physician who worked on my unit, Susan Aben, she would say, if we don't have a good enough history, and a lot of times we couldn't trust the patient's self-report, even if they had a lot of words in terms of telling us their medical history, she would say, we just got to round up the usual suspects. So a little bit of the paper that we wrote when doing this work for 8.5 years in the inpatient unit, seeing hundreds of these folks, we did a series of almost 200 patients and said, we got to look at this, like how often are they ending up on a locked inpatient unit, but really they had some serious medical comorbidities that people weren't finding, or not even that serious, but ones that became serious when they weren't found. And number 1 was constipation, and number 2 was reflux, acid reflux, but there are many others. And we learned that you cannot trust when people say there isn't constipation. We would have to actually get an x-ray of someone's abdomen. And even on top of that, make sure the radiologist knows that we want to know how much stool's content there is, or they would only be looking for major issues. anyhow, this is a set of just some of the things I thought we used to call them low-hanging fruit. We can find constipation and treat it, and that could really improve somebody's mood. It might not be the only reason they're here, but it could be a part of it. In some cases, it was a part of it. It was most of why they were here. You could have acid reflux, urinary retention is frequent with drugs like cogentin that a lot of these guys are on. There's far more extrapyramidal symptoms in this patient population that just for some reason don't get discovered. I worked with a neurologist who is a movement disorders expert, and I used to walk around, do rounds with her a lot. So I learned a lot about this. People have dental issues, mild dehydration, maybe not, their labs look borderline, but they're acting funny. Lots of different problems, including mild sort of toxic metabolic encephalopathy in some cases from Depakote and other drugs. In any case, so I often talk to people about Psychopharm, not because I'm a prescriber of Psychopharm, but because I'm the person trying to help people come up with some other solutions, and we work as a team and we collaborated a lot. So I think I might have given you a copy. I wrote a book chapter with some people from Great Britain about use of psychotropics for treating aggression in people with ID, some of the pitfalls. So the thing I've learned is my doctor colleagues, physician colleagues, prescribers would get really pushed by family members and especially by group home staff to prescribe more medicine, to get control, to find that magic cocktail, the magic pill. And generally we found the magic came from understanding that less is more. So this is the same 50 people. And I just wanted to flash this and say how frequently we found unrecognized extrapyramidal things and dysphasias caused by chronic use of antipsychotic drugs, dystonias, and then if people just didn't see the usual oral buccal movements, they wouldn't recognize it. And a lot of people with sedation. This is I torture my daughter, Nicole, I only have one kid, and I always told people she was so well behaved when you see this picture, and then I woke her up. She was not someone who liked to get up in the morning for school, and she was indeed quite calm in that picture. I often remember Amy. Amy was a patient we had who came onto our unit, and her group home people ended up telling us about her, because I always insist on hearing as much as they can, but they would tell us about her. And they mentioned that Amy had all sorts of agitated behaviors and changes and regression, and she wasn't talking, and they thought she was psychotic. But the one thing that stood out to me is they said, she's always staring at the ceiling. And then we observed her, and lo and behold, she had an oculogeric crisis. So we ended up giving her, medicating that acutely. And she even came up to us and spoke for the first time in a while and asked for more of the medicine because it made her feel better. But people who were working with her didn't see that as potentially being a side effect that was driving a lot of her ongoing struggles. There was something that started her problems, and then there was something that kept it rolling. And what kept it rolling is what we could help. So as I mentioned, polypharmacy has its pitfalls. And Sheehan and Hasiotis are colleagues of mine from Great Britain, from London. And they wrote many papers, again, because they are people who are specializing in intellectual and developmental disability psychiatry. And they have protected research time as well. And I think I included that paper that addresses the fact there's elevated risk for movement disorder challenges in this population. In fact, on my unit, I was glad to see this paper because it verified that we hadn't lost our minds. We saw more neuroleptic malignant syndrome than our colleagues saw on the other unit that didn't specialize in treating this population. And so in any case, a lot of movement disorders symptoms were happening with the newer antipsychotics. I know there's this idea that they don't cause it, but we're talking about a population with an impaired brain. These are people who have fragile neurological substrates, and they're at elevated risk, especially if they're starting out congenitally with things like hemiparesis, cerebral palsy, and even more subtle problems in terms of neuromotor systems, that they are at risk for other kinds of problems as well, because they congenitally have all sorts of atypical, I used to call it body architecture is off. And so you see more of all sorts of troubles, more sleep apnea, more other kinds of things as well. Anyhow, one case that I had recently really upset me. It was a 24-year-old, and he had a bowel perforation because people were so focused on his aggression. They missed that something medical might have been actually causing the uptick in his aggressive behavior. And he ended up, now he has a colostomy. So in any case, eliminating drugs is pretty hard to do as well. So when we would try to taper antipsychotic drugs that have been prescribed for a while, it was hard to stop them or lower the doses. And it was really, even when it was pretty clear the drugs were ineffective. And then I learned about discontinuation syndromes that most people are aware, like, of course, that benzodiazepines, that you can't taper those rapidly or stop them suddenly. But it was also true of antipsychotics and other drug classes as well. But in particular, we were often trying to remove antipsychotics that weren't working and were giving people side effects. And I learned that if you have extrapyramidal and other movement symptoms on the antipsychotic drug, that it can be more difficult to taper it. And then also, remarkably, caregiver attitudes have a lot to do with whether you can successfully taper drugs. And I learned that you need to do it more slowly with some people. One of my expert colleagues, Robert Sovner, used to say, go by 10% of the total dose for outpatients, 10% of the total dose every month until you get down to the lower doses. And I know that you can go more rapidly at the higher doses, but when you get to the lower doses, then the discontinuation syndromes emerge. I mean, you could have relapse too, but in many of the cases we were talking about people, it was really clear the medicine really wasn't helping. So anyhow, you have to understand that discontinuation syndromes really increase the risk of aggression. So the irritability that goes along with these syndromes often predisposes to much more mood dysregulation and challenging behaviors. Akathisia is probably the worst on the medicine, and as a discontinue rebound phenomena can be the most difficult. And then people think it's just part of the ID or the autism or it's ADHD, and it's really important to try to differentiate when it's akathisia. And my colleagues are complaining a lot about akathisia secondary to higher doses of Abilify. So number 8, know what makes them smile, not just what makes them agitated. This is something that I also learned over the years, is that, we want to take really good data. So for those of you who take data or help take data in these situations, I take 24-hour interval data and look for patterns about the context. What's going on in this person or around this person or in their environment that is associated with a higher probability of risk for aggression, and what's going on when there's a lower probability of this. So then I would make a table. For example, there's 50 incidents here, and everyone said this guy got really aggressive when his family visited. And guess what? The probability of occurrence of aggression was much higher when we were training new staff or when he was constipated. So we looked at all these various factors in association with the frequency of the aggressive outbursts, and we could show this with data. In this case, the woman, people just didn't believe that she didn't feel well, but she had a problem called Cornelia de Lange syndrome, a genetic syndrome associated with extremely high rates of acid reflux. And she would cry when she didn't feel well, and this was associated with increased aggression. And we finally focused in on her medical issue to improve things. You hear a lot about attention seeking and people who engage in aggression to escape situations. It's normal to want attention, and there are lots of situations it's smart to try to escape. These guys often just don't know how to convey what it is that they want in a reliable and socially understandable manner. So I've given you some examples here of how I might use the data to look at patterns and find out. I might get suspicious just by time of day. I just looked at a set of data where the agitated outbursts occur around meal times, and they occur after the meals. So there might be some stomach upsets going on. You look at the data in lots of different ways for the clues of the contextual influences on the occurrence of the aggression, because I'm so much better at preventing than I am at responding to people with aggression. So number 9 is, idle hands are the devil's workshop. Grandma said, well, one of the things on my unit that was associated with reducing the occurrence of outbursts and upsets and aggressive behavior was to have a visual written schedule of activities and keeping people busy. And that you want to, I know on a regular inpatient unit, I would help people do that too. That wasn't a specialty unit. They have somebody with autism. We're going to make them a visual schedule for the day, and staff are going to help them keep busy as much as you can. I went and bought sensory modulation tools for some of these units and brought them in. You want to use these tools as much as you can. And people would think, well, we don't have enough staff to put all this time in with a person. It's like, well, you're going to put all the time into reacting if you don't put all the time into prevention. And you can prevent many, many, many more of these episodes than you may think that you can. I'm sure that you can do it. The last thing that I'll say that I learned a great deal about is that happy people don't tend to throw chairs at you. So instead of just focusing on, and this was teaching my staff, I had a lot of people who hadn't worked with this population, my unit was new, was understand, that we're not here to control people and we're not here just to manage them. We're here, we want to manage things, but we want to have the focus on promoting wellness and happiness. And again, it sounds sort of trite. And oh yeah, that's really nice. But I seriously feel like that was how I could control and contain and manage outbursts better, was understanding how to put a smile on somebody's face, keep them busy. In the ABA world, we talk about really high density reinforcement for all the positive acts. We had acts that people engaged in. We had a point system, and then some people couldn't understand the points. So we had cards with stickers on them, and people would run down the hallway to show me all the points that they made and the stickers that they had, because this represented a concrete observation of their success. So we only gave positives. We never took things away, and we just moved people on. You have another opportunity to earn something. Let's go do that. And it was very, very helpful and useful. So lastly, I wanted to say there's a village involved, so include the village. I know it takes extra time to do things like meet with the people in the community. And I know that the Mount Sinai people, actually, I've been to meetings with you guys, so I know that they've taken the time, but it just to everyone to let you know that, it's really important to insist that these guys are involved, not just that they come to meeting and tell you what they can't do, but that they have assignments, and that when you get back, they're going to report up on what they've done so far. And I really think the admissions meeting is critical, because again, to get all that information that I've been discussing with you that helps you to do a better job of preventing aggressive behavior and containing aggressive behavior. You got to get that history. Insist on getting some records. I have to fight with people all the time, but I push and push and push to get the history, to get the records as much as we can do that. And then I always ask people to start with the last time the person was well for a substantial period of time. What does that look like? And then walk me forward. What's changed since then? And please don't tell me your hypothesis of why they're acting badly. Tell me what you saw. Tell me exactly what you saw and what's changed. And then I'm going to work on my differential. So it takes a village. So, we got to keep them going, and we want to know about things like mood dysregulation, but we also want to know about people's other parts of their life, mental status exam. We want to ask the informants about their mood, their speech, their eating, their GI status, their sleeping, their thinking. We want to set a discharge date. I would set a discharge date the day someone had their admissions meeting. And if I have to change it, I'll change it. You want to keep the patient support and team and family working, as I mentioned, all the way through participating, and then being clear about what you can do in a hospital. I'd have to say to people, I can't make, if this person's like miserable where they live, I can't fix that on my inpatient unit. You have to go do some homework on that. I can't do it. I can advocate, I can write a note that says this is what we urge, but I can't make that happen out in the world. You have to do that. So we have to really collaborate with that system of care. I'm just checking for time. I'm just about, I knew I was going to run out of time, sorry.
Oh, no, we are good. We are good with time, Lori. You have,
okay.
You have until 1 o'clock, actually.
Oh, I do. Okay, good. I thought I was running out of time. You know what? I read my clock wrong. So anyhow, prevention first. So I've kind of done a summary of the top things that I look for, and that my really brilliant colleagues that I worked with on this inpatient unit, from whom I learned a great deal, the physicians that I worked with and the nursing staff and all the people that I worked with, is that we treat those medical problems. And I remember having someone say, well, they're not on the inpatient psych unit to get medical care. And I'd say, well, you know, in some ways they are, because we're going to work on treating those things. And it's very, very important, because that's what's driving the mental health issues and the challenging behavior issues and the reason that they're in the inpatient unit. So like I said, we would round up the usual suspects if we had to. We'd cast a wide net. I became expert on how to get people through medical tests. So I and my staff would have to go with them to go do something like a barium swallow. I'll never forget doing a barium swallow with a person with autism once. But many of these tests. The other thing I learned from my colleagues, and especially this neurologist who's a movement disorder expert, and other people that I worked with, that benzodiazepines, people avoid them like crazy in the population. I'm not sure why. We had extreme examples of successful use of benzodiazepines to help people with anxiety and to reduce neuromotor symptoms that were side effects of, say, withdrawing an antipsychotic medication, because they help with muscle rigidity, they help relax people, and using them acutely for outpatients to get them to medical appointments. And I know people do that sometimes, but then they don't recognize that in general, you might have a person, 25 to 30% of our inpatients have epilepsy. And these can also be a tool. Cogentin, on the other hand, I've had person after person after person that my colleagues and I recognized they had urinary retention, constipation, and even, some mental confusion with way too much of a load of anticholinergic drugs. And the anticholinergic drugs were knee-jerk given to support the use of antipsychotics that weren't very helpful. The antipsychotics, interestingly, were often helpful short-term. And if you look at, I don't know how many people know the NICE guidelines that they use in the UK, but they suggest that the use of antipsychotics in people with autism spectrum disorder should be short term if you're going to use them, and you're not treating psychosis. And then you move on to a more multimodality plan that includes lots of non-medical interventions as well for most of the folks in this population. So the other thing is, in order to lower the medications, you have to convince the caregivers. After some of the research I saw from the people and the Dutch investigators, that that they have to not be afraid. So even if you could show people the medicines haven't helped, that's why you're here seeing us, because it's not working. So if we take it away, you can't then expect the person to go to pieces, because when the staff persons expect the person to go to pieces, they go to pieces. And I kind of half jokingly call it reverse placebo by proxy. So we see a lot of placebo effects in the population of people with autism. All the new treatments seem like they're going to be fabulous until they're not. But in any case, you also see people scared to death that if you change a pill, everyone's going to get really, really agitated. And they will if you think that's what's going to happen. But if you have a plan, and I gave you a handout that has some steps that I present to people when we're trying to make a plan to back off of medicines that aren't working. It's not, again, there are people for whom the medicines work great. Believe me, we used a lot of them. And I'm mostly talking about when we just can't seem to figure out why it's not working. It's again, did we miss something medical? Have we got the diagnosis wrong? Are there medicine side effects going on here? And then my colleague, Dr. Strategos, and I are always saying, geez, somebody has so much anxiety, history of trauma, the only medicine they're not on is an antidepressant. And I'm not sure why, but it seems to be, again, like almost knee-jerk that folks, if they have intellectual disabilities or autism spectrum disorder and they hit people, they're going to get an antipsychotic. And it's not always the right pill. It's not always the right medicine. So I think you do need to be really patient and calming and reassuring and guiding with these individuals, even if they're kind of loud, and I'll say it, obnoxious, even, doing things that are very upsetting to my nursing staff. I remember a nurse, and I was so excited, this male nurse, he was a great guy, and had some experience with the population, but not very much. And he came to me to complain that this patient we admitted was so awful. The thing she was saying, horrible things to people. She was, screaming, she was uncooperative, all this kind of stuff. And I said, my God, she's going to have to go to a unit somewhere where they have expertise and help people who have these mood dysregulation and disruptive behavior problems. And then went, wait, that would be us. And, we laughed about it because it was hard to take. So we had to also support each other a lot in some of what was going on, because your staff get traumatized when there's, the imminent aggression every minute and lots of insulting things. I once had a contest about who got called the worst insult this week, just to take the pressure off, because there was a patient on the unit who would try to find ways to make people feel bad. So I hope that I've given you some tools for prevention and, to think about that. And in terms of the data stuff, I threw some data tools in there in case there's anybody, psychology people there who might be working with that. But if prevention fails, the other thing I ask all of my staff to do is really to observe carefully as possible and ask informants, is there even the slightest early sign that somebody's going to get upset? I mean, I'm talking like they get a look in their eyes where they're staring off to the side and they won't make eye contact. They're wringing their hands, they're pacing a little bit, they stop smiling, whatever it is, that's when we have an intervention that everybody does. And all my plans had an intervention. The START teams have crisis plans, and they have a stage 1. This is the first thing you might see. And then here's some things to try and do. And that's critical because, again, I don't want to be reacting and responding to aggressive behavior. When, as a consultant, when they would say, Dr. Charlo, what do we do if he throws a chair? And I would say, duck. Because at that point, I don't have like the answers that you want and have the magic answers. We have to go back and we have to do all this elbow work, and we have to be a little bit like Sherlock Holmes. So anyhow, I have a specific plan about those early warning signs, and that might be when I can just get somebody, bump the needle out of the groove where that, that set shifting isn't working, and you get them out of the hallway or do something, sing Elton John songs if I have to, whatever it is. And then, a lot of the incident reports I read, staff will complain to me that this person is attention seeking. They're doing their attention seeking. So I read the incident report, and what happens? People give the most intense attention and counseling and all this kind of talking to people when they do something like engage in a challenging behavior. We all rush around and say, and tell them that's not nice or don't do that. It's not really usually the counseling moment. I sometimes use distraction. It can be really helpful. And I think I have an example of that coming up, and a misspelled word. So in any case, I want to distract somebody if I can't counsel them and return to normal engagement, get the needle out of the groove, as I mentioned. So keeping people engaged and distracted from worrying is very helpful, and that's why distraction can be helpful. I've also learned that for a lot of these guys, it's a term in the behavioral world we might call behavioral momentum, where if we, the more time that we can extend people feeling safe, cared for, and relaxed, the more time they will be relaxed and happy. It builds, and there's a momentum to it. And the other way that we do things is that when we have those schedules, we do something that makes a person smile, work in something that's a little harder to do, and then have another thing that makes them smile happening afterwards, using a lot of pictures. I actually gave an example of a PowerPoint that my evaluation team used with a person with autism that gave pictures, and there's a few words, pictures and words on each of the PowerPoint slides that shows the person before we came, what we were going to do, what the doctors were going to do, how we were going to talk to her, take her temperature, have her walk for us, all that kind of thing. And everyone said she doesn't need that. She talks just fine. And it turned out that when we went there, the physicians forgot one of the steps that were highlighted in the slides, and she had them called back to finish, to do the eval the way it was in the slides. So she paid so much attention to the pictures. It was really, really important. Avoid focused processing of negative events. I'm just going to mention this because you know, Susie would talk incessantly about her tragic events, and she kind of exaggerated. It started out with something that truly happened, and then it built into, I think she was saying that her father ran her over with a car 3 times, and he really didn't do that. But she had such tragedies, and she would be very agitated, and she was journaling about them, and she'd work herself up. And I remember that I explained to her that she was making me too sad, and assigned her a very concrete task of go and write with the staff helping her the things that made her happy, what she likes about herself, and what she's looking forward to. And again, it sounds kind of trite and simplistic, but over a period of time, she was running down the hallway to show me the positive things. It's shifting, jump shifting that constant thought. It's a little bit of modified CBT. It's jump shifting the focus on things that don't need to be associated with being agitated. It's really, really helpful. And being like really creative. I work with some fabulous creative nursing staff and direct support individuals. This guy would stand in the middle of our quiet room and scream, and he'd hold his hands over his ears, and what he would scream, I can't say, but he was going to blank and kill you. And it was scary. He was big, at least a 6-footer, really large guy. And someone came up with the idea, a couple of the staff people that were direct support staff that were working for me would stand outside the door around the corner so he couldn't see them. And they would talk in a low tone, except make sure that he could hear that they said his name. And he got quieter and quieter and quieter because he wanted to know what they were saying. I can't blame him. You know, it was one of those things. But it was like really creative. I said, wow, he totally calmed down. I think he forgot what he was upset about by the end of it, and they could move on and do something else. Marguerite refused to get out of bed for activities. And one of the rules on my unit is you really basically had to be really ill to stay in your room and stay in bed. We just worked our hearts out to make people, I told you, when people are busy, they're less violent. When people are busy, they're calmer. They're distracted. They don't have as much anxiety, which is so common. So anyhow, some of my staff were like at the point of this being a problem for a while was like, you know, maybe we should just like dump her out of the bed. It's like, no, we're not going to do anything like that. Or she needs to be medicated or whatever. And I said, no. So what we did is we created a conga line, and we all danced into her room and danced her out of bed and into her group. And there are many other kinds of creative strategies. These are just a few kind of silly, fun experiences that I had where positive outcomes did occur. So Law 14 of the House of God, there's a sequel book to the original House of God. I actually read a little bit about that, and it's an interesting thing that was said is that this applies not only in medicine but in any of your significant relationships. If you are connected, you can talk about anything and deal with anything, and if you're not connected, you can't talk about anything or deal with anything. Isolation is deadly and connection heals. So it's sort of one of those really important lessons in the work with people with autism spectrum disorder and intellectual disabilities, that it really truly takes a village, and you got to keep the village working and connected. So I have all of these references here to get through, and hoping that I think I gave you a lot of handouts, and just wanted to share some of the tools and resources that I've depended on and that I've used when helping others in the past. And I hope people will reach out to the START program. So if you have people with intellectual disabilities and autism spectrum disorder, I think people know to reach out to OPWDD, but to reach out to the START program. And I should even make sure that you have Stefan, my boss's email, so you can get in touch with him, and make sure that somebody who ought to be connected to that START outreach team is connected, so they can help you, so that people don't get stuck in the hospital where, you know, they need to be helped to go home. And the one thing I apologize, I don't know how to do, is get the system in gear all the time. I think that takes a real village to do that, because it is things have been difficult out there since the pandemic. So thank you.
Thank you, Dr. Charlotte, so much for this great presentation. I hope that anybody working on an inpatient psychiatric unit in this country was listening, because it's really so valuable, because, you know, these patients end up at our facilities, end up on our inpatient units, and quite frankly, you know, I can speak personally, was not trained specifically how to manage this population, and I think few people are. And if this talk alone could be included in training, or at least for people to early on in their career learn this, I think that so much damage can be avoided too. You know, all the things that you were saying, they resonate so clearly with us, having had, you know, many of these patients, and like you heard, you know, one significant example that is still ongoing, and you know, this idea that, you know, meds and more meds is the answer, when in fact it's probably the opposite of that. I want to open up the Q&A. So we have some questions, and I wanted to also ask, so, you know, you mentioned a couple of times that it takes a village, which makes perfect sense, because, you know, there's so many staff on the unit in general that participate in the care, and that we rely on. So was wondering, is there any particular kind of training for the staff that we could, you know, very practically think of when we have somebody with autism spectrum or IDD that needs a lot of care and like one-to-one attention? Any ideas on that?
Well, I think it's interesting, because when I was at UMass for like 15 years. So I used to routinely get invited to talk to the psychiatry residents. When the unit was open, they could do a rotation on the unit, but it had to be voluntary. It wasn't like mandated or anything. I think they did like a 3-month, you could do a 3-month rotation on the unit. And so I got a lot of chances to do some educational stuff. The only thing I can think of is to try to institute like at least an annual, biannual session for your upper residents there, at least, you know. We also did a thing called the interclerkship for the medical students. So I think we did one for the medical students where we did an afternoon on this topic. And then annually I would do the psychiatry residents one. And it's not that hard to arrange that, you know, I think, and in collaboration with the local START program, they'd probably, you know, help you do that and want to do that, you know, be happy to do that. So we should talk later, and we'll make sure you have that access. I think people who are super interested, one of the things that I've been doing is I do multiple multidisciplinary assessments every 3 months. I do 3 for the state of Massachusetts. I've been doing them for Maine. I've been doing them for other, for the state of Connecticut. And then we do them off and on just by word of mouth. And we do training there too, when people have, people have not had as much time during the pandemic. But if we get back into gear, we always allow at least 1-2 guest trainees. So it's something, and sometimes I've had them from other hospitals besides UMass. So we should talk about that too. If somebody wants to sit in and just sort of hear how those guys do that interdisciplinary discussion, where somebody's got epilepsy and they've got serious psychiatric issues and challenging behaviors and medical comorbidities, and I'm there to talk to them about their positive behavior support plans are too restrictive or punitive and get them on a different course. We all do that together. And you know, I've had people visit those team meetings if you'd like to sometime.
And those are all great ideas.
I'm going to jump in, Jan, and just say, as training director, the residents now do get, Katie Straticus does teach them.
That's right. You know,
Right,
and I
yeah.
know that. And she just texted me.
Right.
I know she does that.
Right. So she teaches, but it's a little different to do the didactic thing than to really have, I think the practical things you're describing, Dr. Charlotte, are
Yeah.
really, you know, I think somehow the unit learning that together and the residents on the unit together with the staff, if we could get some, that's, I think, would be an added level that would be really helpful.
Right, yeah,
But
yeah.
I can help facilitate that.
Yeah, it's different than what Katie does. Yep.
And I also was thinking of, like, not just the residents and trainees, but like, say, our one-to-one staff, right? Like the actual PCAs and the MAs that are like really handling the patient on a day-to-day basis. How do we train them? Because a lot of them are like, you know, from agencies. I don't think they get the right kind of training. So having some level of unit training, and even if that could be a recorded sort of training, right, that we can show every time there is a staff change or like a rotation change or something to that effect, I think would be so useful.
I agree. Like, I think if you really have to win the hearts and minds of your nursing staff and, you know, the people on the floor, because, you know, it's great if we think a certain way, but if they're frustrated and I don't know what to do with this guy and I've been so nice to him, why does he want to hit me? You know, that's really, it's important to help them understand where that's coming from and to give them tools.
Exactly. I mean, the example that you gave of the creative behavior of the staff that decided to like call this, like just talk softly with, I mean, that's amazing. That's really that talks about if the staff are engaged and if they kind of want to be involved and own it, then it's so much easier to manage.
Yes. No, you're nail on the head. Yeah.
I also want to get to one of the questions from our audience. So I have a question here. You mentioned the apparent overdiagnosis of other disorders like bipolar and psychosis in the IDD-ASD population, and you also mentioned children. I'm wondering if you have any suggestions about how to more helpfully work with parents and families in relation to this, helping them to better understand what is and isn't going on for the child and to more supportively respond to the child.
I think, again, like if it's a person, I keep going back to START. So I would look at my local resources in the START world. They will take on children as well who have comorbidity of, you know, intellectual disabilities, autism spectrum disorder, and psychiatric and challenging behavior issues. And they even have outreach where they would send a person to the home a certain number of hours a week for a short-term period where they will help the parent and in collaboration with the clinicians talk about maybe this is a kid at home that needs a schedule on the fridge and some sort of rewards during the day or communication tools or whatever it is that they can go and help kick that off at home, or they can help talk to the school system, et cetera. And again, pull that village together around and for the parents. And, you know, I think that they can be helpful in that regard. I mean, otherwise, that's what I would, you know, it's one of the things that I would be trying to do on my inpatient unit is, you know, talking to parents. One of the things that's most important chronically with these individuals, and even in the acute situation, is to call a parent and say when something's going well. I know it's often the social workers, but it's like they only get called when like, oh, I'm sorry, we had to hold your son down today and shoot him up with, yeah. And they don't get the call when, he had a great afternoon. I just wanted to make sure you knew that he got out of bed, he got out of the room, he came to some groups, he seemed to be laughing and enjoying himself. I just want to make sure you knew. And those things are like so powerful because these parents, all they get is bad news, As far as like the differential diagnostic thing, I think like I even had a hard time once people, like hear your case formulation. So we sort of live in the checkbox society of, check, for these symptoms. And it sort of go back to the olden days. They shouldn't be the olden days of, lengthy differential discussions with case formulation. And for me, it's the looking at the context in which problems arise and diagnostically explaining to them, well, I know it kind of looks like bipolar disorder because he runs up and down the hallways and he doesn't sleep and he gets upset, but he did that since he was 3. And guess what? That probably isn't bipolar disorder because that wouldn't start sort of when you're 3. And, I would try to give rational, logical explanations why, it's just not coming together. And, usually I can get people there. I think it's more, using less, I call it psychobabble. We use a lot of our special terms. And when I'm working with direct support people and with family members, it's trying to translate, psychiatric and neuropsychiatric language into everyday stuff for people.
Yeah, that makes a lot of sense. That's one of my pet peeves too, when people approach family with all sorts of, the lingo and nobody understands what's going on.
Right.
All right. Well, I think we're going to wrap things up. Thank you so much for this wonderful talk. It's been very, very informative and helpful. And we're going to move things on, and I'm going to ask Dr. Vora. I think she's going to jump in and just give a quick outline of the rest of the afternoon.
And I'm going to do a quick goodbye because I'm running out the door on my vacation. And thank you again for having me.
For your vacation.
Thank you.
Thank you for doing this.
Thank you so
Enjoy
much.
your vacation. All right.
Thanks so much. Take care. Bye-bye.
Yeah, so I'm going to just jump in really quickly and just go over the format of the symposium, just so that, because we got some questions along the way. So the next, for the next hour, we're going to have one more speaker just like this, Dr. J.P. Lindenmayer, that a lot of us in the New York area know very well. He will be talking about the clinically challenging psychopharmacological cases that we have, the challenges we have on the unit. We will have a similar question and answer session moderated again by Dr. Rosenthal. And then we're going to take a little bit of a break. We're going to have a break from 2:15 to 2:45. And then at 2:45, we're going to have a panel of 3 of our experts here, Dr. Serta, Dr. New, and Dr. Roselle, who'll be joining a little bit later. Where we'll be the 3 speakers will be speaking separately, but then also sort of with each other around patients that are, suicidal, violent, borderline personality, all of which generally tends to go together on the units. So it'll be like a panel, and then there'll be questions and answers for all 3 of them. And that'll be sort of like the end of the session. So we kind of just wanted to let people know there's a little break between 2:15 and 2:45. Again, this whole symposium is being recorded. So if you do have to step out, step back in, we will be sending out a recording. And then the CME link is also on the chat. So, as per the rules of AMA and APA, we want to make sure that you're going to claim credit commensurate with the amount of time that you spend attending today's talks. Thank you so much again. I'll now let Dr. Rosenthal introduce Dr. Lindenmayer.
Hi, good afternoon. I'm Dr. Blake Rosenthal. Thanks so much, Rajvee and Jan. It was a great first talk and definitely touched on a lot of things that we see on the inpatient unit and the struggles that we have trying to meet the needs for such diverse patients. I'm the inpatient unit chief on Madison 5, which is a general adult unit. And I've had the true privilege to train with and work with a number of our presenters this morning. And I'm very happy to introduce Dr. Jean-Pierre Lindenmayer. Dr. Lindenmayer I've worked with him for the last 7 years, so I know he's been in the area for decades more. And we work together when we apply for transfer from the inpatient unit to Manhattan Psychiatric Center, our borough's state hospital. For decades, Dr. Lindenmayer has been a very important figure and developed nuanced evaluations and clear treatments for some of our sickest patients. He trained in medicine in his home country of Switzerland and then completed residency and fellowship at Downstate in Brooklyn. Since then, he's focused on acute inpatient care, and within years was a director at Bronx Psychiatric Center, and then later director and clinical director at Manhattan Psychiatric Center. In this position, we at Sinai really benefit from his clinical expertise and insights and the compassionate care that he brings to these particular patients. His work and extensive publications range in topics from schizophrenia, including outcome predictors using genetic markers and symptomatology, co-occurring OCD and ADHD in patients with severe schizophrenia, catatonia, and really far too many more to mention. In the state hospital system, Dr. Lindenmayer worked also to develop the PANS, the positive and negative symptom scale, which has really become a critical monitoring tool in the treatment of patients with severe schizophrenia. And for all of these efforts, Dr. Lindenmayer has earned extensive grant support through the National Institute of Mental Health. We are very delighted to have him speak on psychopharmacological challenges, and I'm personally looking forward to learning from his talk and those of his peers. So thank you very much for being here, and welcome, Dr. Lindenmayer.
Thank you, Blake. Let me just make sure we can get my slides on. Let's see. Share. Okay. Okay. Can you see the slide?
Yes, we can.
Yeah, excellent. Thank you, Blake. This was a very generous introduction, and I'm really very pleased to share this afternoon with you guys because Manhattan Psychiatric Center is really not very far from your institution. We are essentially across, the East River. On the other side, this huge building, which you see when you go onto the bridge and you sort of drive around it, you think it is a prison, but it is not. It is actually a psychiatric hospital, and which has been downsized over the years. So this huge building, which used to house, I think, what people tell me, up to, I think, 1,500 patients, has right now only 150 patients. So only a very small part of it is actually being used. It also has been entirely refurbished and is a very modern institution at this point. It gives me also pleasure to speak to you guys, because I know that some of you probably have dealt with us quite a bit in trying to transfer patients to us. And at times I know that I may have been a bit challenging, in terms of does this patient really need to be in a prolonged intermediary care facility? Does this patient really benefit from this? Because in the decision-making process, it is really the patient who is in the center of it. Is it helpful for the patient or not? Can we really offer something additional to what you have already done? So today we are going to be shifting a bit the topic here from what we were hearing before, which on the other hand was extremely interesting to me, because many of the behavioral issues which we are trying to treat pharmacologically, very often need to be really addressed behaviorally as well. So even so, I will be focusing on psychopharmacology here. We need to keep in mind that the behavioral parts are really, very important as well. Let me move on. These are my disclosures. We have support from different pharmaceuticals and also from NIMH. So the topics which I want to review with you are listed here. Essentially, first, I want to start with, do we really benefit, or do we need to make the diagnosis? That's an important issue. What are the targets of our antipsychotic interventions, particularly on, the acute inpatient units? How do we treat aggression and agitation? Special issues in inpatient treatment, some of the kind of the special pearls which create this many staff issues. Is my patient really adherent? That's, I think, an important issue which we have to keep in mind. How soon should we evaluate treatment response? Is switching to another antipsychotic helpful? And then some remarks about clozapine, and finally some conclusions. Now, you may be thinking this is sort of a strange question. How important is the DSM diagnosis when we evaluate patients on an acute inpatient unit? In fact, it is probably not, that important, because we are not really treating a diagnosis. We treat predominant psychopathological syndromes. And those are the key syndromes outlined here: positive syndrome, negative syndrome, excitement, hostility syndrome, cognitive syndrome, and depression, anxiety syndrome. That's really what our psychopharmacological tools are geared to treat. So the debate, is this a schizophrenia? Is this a schizoaffective? Is this a bipolar patient? To some degree, should not be really in sort of the first concern. I think the first concern should really be to typologize the patient in terms of these treatable syndrome. And of course, underlying all of this, particularly in the acute inpatient unit, we always consider any organic etiology, essentially also certainly substance use, which might be, an issue. Now, again, looking at in what way, what are actually our antipsychotics helpful with? They do work well with positive symptoms. They do not work well with negative cognitive symptoms. They are probably fairly modestly effective for affective symptoms. Functioning, it's a very indirect effect. The effect where we do see some good response is with aggression, and of course also overall relapse prevention, looking at the post-hospital course. I want to sort of kind of be short on the underlying pathophysiology, but I do want to mention that all of our antipsychotics, they work through dopamine D2 receptors. They essentially block these receptors up to 65% generally. Which is required for antipsychotic efficacy. Lower occupancy, as you probably remember, is ineffective with a few exceptions, and higher occupancy contributes usually to side effects. And certainly higher than 80% occupancy is associated with extrapyramidal symptoms. I'm mentioning this as sort of under the heading, the curse and the blessing of dopamine blockade, because this is where we are, at this point. We do not have any antipsychotic medication which is not a dopamine blocker. The two exceptions to some degree, but these are very, very relative. The exceptions are essentially quetiapine and clozapine, because their D2 receptor occupancy is very low. And of course, this is correlated with a very low liability for extrapyramidal symptoms. Now, with the patient who is coming in into our units, usually these are multi-episode patients. How do we actually choose the drug which we want to use? There are basically two principles at play here. It's the prior treatment response. And I'm mentioning this in in spite of the fact that very often we do not have this information on one hand, or we don't want to use this information. I have to say that because I'm looking at all of the patients who are being referred to us, and I'm very curious always to know, how did the psychiatrist choose the antipsychotic to get the patient started with after the admission? And very often I see that they did not use actually the same medication with which the patient had been treated the previous times. I'm always wondering why. Do they have something which I don't know, which the patient did not respond to? Or is there some personal liking of one drug over another one, which is probably more the case than rather additional information? The other major sort of decision factor is the medication side effect profile. I think those are the two key items which I think we put into our decision making with the first antipsychotic the patient will be treated with. There are some other criteria which we often should be certainly considering: patient preference, what did the patient actually like to be treated with? What is the adherence history with a particular drug they have been treated with? And that certainly will affect the long-term planning. And then also any medical history and medical risk factors underlying, which might mean that we have to avoid certain medications. But it's interesting to think that it's really the history which should inform us very much so, and the side effect profile, not so much the actual, medication mechanism which we are, contemplating to use. I just want to remind you that we have had some newer antipsychotics coming on. I must disappoint you that none of them are in any ways, sort of fundamentally different from what we have. They all are dopamine blockers to a greater or lesser degree. They all have a 5-HT2A, component with it, which may or may not have an effect on their efficacy profile. So we have lurasidone, which has come on. We have asenapine, Safris. We have iloperidone, Fanapt. We have lumateperone, Caplyta. Caplyta is sort of interesting in that sense that it has a very low D2 receptor occupancy. So in that sense, it may be a little bit closer to Seroquel or clozapine. However, it is non-sedating, and it may even have a bit of an activating effect, as it's been also tested more recently for negative symptoms and of course also for depression. We do have the group of the dopamine agonist antagonists, which you are familiar with in terms of aripiprazole, which was the first one, then followed the brexiprazole, and the most recent one, cariprazine, Rylar. They all basically are similar. They are D2 agonist and D2 antagonist. They have to some degree a variable component of 5-HT2A agonism and 5-HT2A antagonism attached to them, if you want. They do seem to be a bit different in terms of intrinsic dopaminergic agonism. I think Rylar is probably the one which has the highest level of that. What is the comparative efficacy of antipsychotics? This is a comparison between the actual antipsychotic and placebo. Of course, placebo would have the lowest. As you can see, it sort of goes up. Here's iprasidone, then followed by aripiprazole, haloperidol, quetiapine, finally olanzapine, risperidone, paliperidone, and the highest level of efficacy would be comparatively with clozapine. So that gives you, again, sort of an idea about when you are choosing the antipsychotic with the patient is coming in, are you, basically looking at what did the patient respond to in the past, which would be probably the main sort of decision helper. Or is it also the efficacy of the drug you're looking for? My sense would be that you first go with the history, you then go with the side effect profile. If you have, of course, clearly a history of non-response, you would be going for clozapine, and we'll certainly talk more about this later on. Now, what about sort of the acute situations which we run into on the inpatient units, agitation and aggression? And I really appreciated Dr. Schalla's description of the agitation aggression sort of complex, that it is a final, common pathway of a number of different mechanisms underlying it, which may to some degree help in the treatment decision for agitation aggression. Unfortunately, we tend not to make this differentiation very clearly, and we end up using essentially antipsychotics in the context of agitation and aggression in a patient with schizophrenia or psychosis. But as you can see, we have drug alcohol intoxication, we have personality disorders, we have mood disorders, psychotic disorders, delirium, we have acute medical neurological issues, we have also cognitive issues, and we heard about with Dr. Charlotte about that. So again, it would be very helpful to have an idea, what is driving the agitation and aggression, and I think the treatment would be much, much more successful in that case. What we use, of course, is usually antipsychotics, sometimes alone or in combination with a benzodiazepine. I just show you what we use at Manhattan Psychiatric Center most frequently: olanzapine, 10 milligrams, usually IM, cyprazidone, 10 to 40 milligrams IM. We also use still, unfortunately, I say that with a certain, kind of sadness, because I don't think haloperidol should be still used, but we do 5 to 10 milligrams, and often together with lorazepam, which tells you also that it isn't really, as optimally effective as you would like it to be. Some emergencies which do occur in the context of antipsychotic treatment. One of them is, of course, the NMS, which can be life-threatening. Here are some of the key symptoms: hyperthermia, profuse diaphoresis, generalized rigidity, early delirium, catatonia, stupor, coma, autonomic activation, and of course the elevated CPKs, which I think we're all familiar with. What are some of the risk factors for the NMS? A rapid increase in antipsychotic dose, so a very rapid titration, IM administration, dehydration, agitation, younger age have also been reported to be risk factors. Treatment recommendations: ECT may be the fastest and the most effective treatment. Of course, the more conservative approach would be hydration, benzodiazepine, which take longer to work, but it does reduce the total number of hospital days. Bromocriptine and dantrolene work faster, but are associated with more total hospital days. Clozapine would be another possibility if the underlying medical conditions are all stable. And then if you reintroduce your antipsychotic, you would do it very slowly, and you would certainly avoid lithium and complex antipsychotic combinations. Now, let me mention a few sort of challenging pearls which we run into from time to time, some more frequently than others, and some of which I'm sure many of you have experienced with your patients. So treatment refusal, that is certainly one aspect which we run into, and there is certainly quite a bit of psychological work which goes on in terms of, trying to figure out why is the patient refusing a treatment. But eventually, when everything sort of has been done, we move on to a treatment over objection. One of the things which I see done in other hospitals, which always is a bit problematic, that a treatment over objection is being proposed to the court with an oral medication or with a IM medication on a daily basis, which in my mind doesn't make much sense. I think we should always request a depot antipsychotic when we go to court for a treatment of objection. I know there may be some courts which are not, really in favor of that. Then I think we should try to educate the judges and educate also the MHLS lawyers, that it's really kind of not humane to inject somebody on a daily basis with an antipsychotic when we have a long-term depot antipsychotic available. Sociopathic aggression, we do run into that occasionally, and we arrest patients actually when that happens. So that is indicated when the patient is found to be aware of the consequences of their action, and they are able to fully differentiate right from wrong. And we do that in a sort of committee kind of review. So this is a fairly standardized and kind of a due process type of a arrest proceeding. And then hospital safety does bring the patient to the local precinct, and the patient gets arrested. And depending on the charge, may have to go to jail or comes back. But it's certainly something we have done, and I think does have a certain deterrent effect as well. What about refusal of oral food and fluid intake? That happens occasionally. Of course, we do close medical monitoring of the input and output. We also use IV fluids, and if the medical situation deteriorates or is dangerous, we have to refer the patient for medical inpatient treatment. What about self-injurious behavior, which is, not infrequent? Obviously, patients will be on one-to-one observation. We remove all objects which can be swallowed or used for this type of behavior. In case of head banging, we use helmets. But when we do use a helmet, it is equivalent to a seclusion, at least in our setting, and we have to follow all regulatory management rules for seclusion when we use sort of restrictive types of interventions. We search visitors of patients who do tend to swallow or to self-injure themselves. And of course, we also use naltrexone, naloxone for this type of behavior. Acute suicidality, ECT, is of course the sort of the main intervention. We also use esketamine and clozapine as well. Treatment-resistant impulsive aggression, I think the best treatment for these types of situations is ECT. After everything has failed, obviously, after clozapine has failed, after other treatment trials have failed, we eventually do move to ECT. And catatonia, which does occur still. In fact, I think we have had sort of an increase in catatonia patients, which we haven't seen, which we had not seen for a while. But apparently it is sort of reappearing, and we do use sort of the standard high-dose lorazepam treatment. So those probably cover some of the sort of the major kind of incidents which we run into, which create significant management problems. One aspect which I mentioned just before is in terms of the suicidal patient. This is an indication of clozapine which has been forgotten to some degree. That clozapine is actually the only antipsychotic which is indicated for suicidality, which has the FDA indication of suicidality in schizophrenia. So you do not need to have treatment resistance in order to use clozapine for this situation. It is based on the Intercept study, which some of you may remember. This was a comparison between clozapine and olanzapine. This is probably one of the longest RCTs in patients with schizophrenia with active treatment, comparing to second generation antipsychotics. It compared clozapine to olanzapine, double blind. So everybody, all patients were treated exactly the same way. And the outcomes, which you see here, patients with suicide attempts or hospitalization, was significantly lower for clozapine as compared to olanzapine. Patients who had significant suicide attempts, again, the same difference. Hospitalization to prevent suicide was again higher for the olanzapine patients as compared to for the clozapine patients. And in the clinical evaluation, patients who were much worse in terms of their clinical, you did actually also see a kind of a winning of clozapine over olanzapine. Again, these patients were not treatment resistant, so they had essentially a history of active suicidality in the recent past and were randomized to one of these two conditions. And this is a very rare event that the FDA would approve a indication based only on one trial rather than the standard 2 trial, which is usually and typically required. And they did this for clozapine. Moving on to the question is, how do I know that my patient is adherent? And it's a question which I'm very much interested in, because it's something which really occurs in our clinicians' lives with our patients constantly. So how do we know it? Well, one, easier response is, of course, if the patient is responding to the drug. That would be a fairly good, conclusion. If we have an active plasma level, that would be even clearer. And if the patient's receiving a depot antipsychotic, which then, which basically certifies that the patient has been receiving medication. Predictors of non-adherence, in a smaller study which we completed recently, we saw that pre-admission non-adherence, so of course a history of non-adherence in the past. Baseline hostility was a significant predictor for non-adherence, and also baseline medical somatic concerns, and that has to do mainly with side effects, of course, of the antipsychotic. In this context, I do want to mention the importance of the plasma level monitoring for antipsychotics. This is a nice study recently done on 99 patients who were referred to this particular team who had apparent antipsychotic resistance, and they were considered for clozapine treatment. They did plasma level assessments and found that 35% of this cohort had subtherapeutic antipsychotic plasma levels. And of these, 34% were undetectable, actually. So essentially, they were not taking their medication. Lower dose was associated with low plasma levels, as you would expect. These patients also were more likely to be readmitted repeatedly. So therapeutic drug monitoring is, I think, the only clinically proven approach for demonstration of adherence. And unfortunately, it's not something which we do routinely. If I look around in terms of our inpatient units who refer patients to us, it's not something which is routine. Usually, we have to request it. Also, our labs, laboratories are not apparently really equipped, which is surprising. Most labs in the inpatient units who refer patients to us, are specialized in doing clozapine and lithium and valproic acid. But once you ask to do, any antipsychotic level, it usually has to be sent out, which tells you that this whole issue of therapeutic plasma level monitoring seems to be not really accepted or has not really moved into clinical day-to-day practice, which I think it should. I think this is really overdue, and there's enough data to really support this as a very, efficacious way of kind of testing for adherence. Better adherence with deeper antipsychotics, that's certainly something which we all know we have good data for. Advantages that we know whether or not the patient has been taking the medication. I think that is really the most important advantage, because of course adherence is only there if the patient accepts the injectable and comes back for the injection. So it's not an automatic assurance for adherence. The disadvantage, yes, poor patient acceptance. There's also a rather poor provider acceptance, because I think many of our colleagues are not comfortable with depots. Low flexibility in dosing, and there's also a pretty high cost of the second generation depot antipsychotics, which is unfortunate. In my mind, it should be the standard of care for most patients with repeated psychotic episodes, whether they are, young, whether they are, in the middle of their, pathway in chronic schizophrenia, or whether they are, at the at the end stage of it. I think it is really part of the standard of care, which is unfortunately not, being published by the APA. Some of you may have seen, I think the new guidelines for schizophrenia came out about a year ago. And if you look up on the depot antipsychotics, they still have it at a pretty low level of urgency. And it's based on patient preference, which I don't think is really the best way of addressing this. What are the newer depot antipsychotics? We have Invega, Sustenna, and Trinza. We have, of course, the old Consta. We have olanzapine, Relprevv, which is not very much used because of its potential side effect. We have the two aripiprazole depots. And we do have recently a 6-month paliperidone, which has just come out, which is very interesting. And we also have a new subcutaneous once-a-month depot preparation. My own wish, in fact, would be that we had a 1-year depot antipsychotic. I think that would be really my best wish for this area. So how soon should we be evaluating treatment response? This is sort of an interesting topic, and again, is something which we may not be paying enough attention to, because research is pretty strong in telling us that the response does occur within the first week or two of the antipsychotic treatment. So it's not a question that we have to wait for weeks and weeks to see whether or not a patient responds. Patients identified as early non-responders are not likely to become responders with continued exposure. This is a nice study by Samara. They looked at 34 short-term studies with 9,460 patients. They used as a measure of response a 20%, at least a 20% response on the PANSS or the BPRS after 2 weeks. This lack of response predicted non-response at the endpoint with a specificity of 86% and a positive predictive value of 90%. So in my mind, that's a pretty strong indicator that after 2 weeks of seeing or not seeing a 20% reduction in your ratings, that you can pretty much predict whether or not the patient will be responding or not. And that is something which should be guiding really our treatment, essentially. Looking, of course, also, if the patient does not respond, is the patient a candidate for clozapine eventually? Another way of demonstrating this fact, which I think has now been demonstrated by many others, this is an old study by Kynan, where they treated acutely psychotic patients who had been coming into their hospital for 2 weeks with risperidone. So they evaluated them after 2 weeks. Those who did respond here in the triangle were continued on their drug for 12 weeks. And of course, they continued to improve further. Those who did not meet the response response criteria were then randomized to change either to stay on their risperidone or to change to olanzapine. And as you can see, the number of patients was clearly pretty significant. So they had a pretty good statistical power. And look what happened. So the responders, obviously, they remained responders, but the ones who had not responded, even with a switch to olanzapine, did not really do that much better. They did respond a little bit, but in no dramatic way. So there are two questions here, which I think are indirectly answered. One is that you can evaluate your response of your patient after 2 weeks, and you have a pretty good idea what will happen in the following weeks. And if you are switching the patient to another drug, it is probably not going to do too much to your response. And that is, I think, something which should really inform our treatment, in terms of what do we do if this happens in terms of the non-response. What are some of the risk factors for poor treatment response? So we have some factors which we cannot change, obviously. Male sex, younger age of illness onset, poor premorbid adjustment, greater number of relapses, longer illness duration, and again, this early non-response at week 2. What are some of the modifiable risk factors? Longer duration of untreated psychosis. Of course, we might want to, treat patients very early on. Comorbidities, where we may have some impact, greater illness severity, and non-adherence to treatment. And that is certainly, again, a very strongly modifiable factor. So let me bring in a case vignette which might exemplify one or two of these points. So here we have a 60-year-old male domiciled in a residence with psychiatric history of schizophrenia, violence, many psychiatric hospitalizations in outpatient treatment with a PROS, and has a medical history of cardiac failure, was admitted due to psychotic behavior after setting fire in the context of non-adherence. He was supposed to be taking olanzapine 20 milligrams orally. So the patient was initially placed on olanzapine 20 milligrams twice a day and valproic acid, BID for acute psychosis, including auditory hallucinations to harm others. After 2 weeks of treatment, I presume because the clinicians felt that the patient was not responding, haloperidol was added at 15 milligrams twice a day due to non-response. He became calmer over time, no longer yelling, but continued to be disorganized with significant auditory command hallucinations to harm others. So there are two sort of clinical conclusions here. So A, he did not respond to the initial 2 weeks of olanzapine, and he also did not really respond with the additional, haloperidol. Now let's go to the next slide. So given his refractory psychosis, clozapine was considered. However, it was ruled out due to his history of reduced ejection fraction. He was transferred to us, to MPC, on olanzapine, valproic acid, and haloperidol in the same dosages. On arrival at MPC, we took plasma levels of olanzapine and haloperidol, and we found that they were both subtherapeutic, except for the valproic acid, which is, by the way, something we often see, that patients seem to be taking their valproic acid, but not their antipsychotic. Olanzapine was changed to Zydis. Haloperidol was changed to aripiprazole depot, 400 milligrams IM. Patient recovered after 6 weeks sufficiently to be discharged on this combination. So two conclusions. I think therapeutic plasma level monitoring would have shown to the clinicians in the referring hospital that the patient was actually subtherapeutically treated, so that the combination of olanzapine and haloperidol was clearly not working, essentially because the drug was not, entering the CNS. we opted to add to the olanzapine the depot antipsychotic in form of aripiprazole, based on the Finnish study, which some of you may have seen, which was a huge database looking at what combination of antipsychotic prevents rehospitalization, and the best one was clozapine, or a second-generation antipsychotic in combination with aripiprazole depot. So that was based on a research finding. So what about this partial responders? First, keep in mind, we do have now pretty good definition of treatment non-response. We do require duration 2 trials, each one of 6 weeks at a therapeutic dosage. Dosage of past trial, it should be equivalent to at least 600 milligrams of chlorpromazine equivalents. And the number of trials are 2. However, one of them should be utilizing a long-acting injectable, again, to confirm that there was actually treatment adherence, or that antipsychotic was going into the system. Now, before people often move on to clozapine, the first reaction is always to increase the dose. Let me just tell you that this is a futile attempt, because we have ample evidence that it's not any better than the usual dosages. So we have a study of 600 versus 1200 of Seroquel, which did not show any difference. We also have a study of olanzapine comparing 10 to 20 to 30, 40 milligrams, which also did not show any difference between these 2 dose ranges. We have a high dose risperidone depot study, 75 of 100 milligrams. And we also have a high dose lurasidone, 80 versus 240 milligram, and did not show any advantage. It makes a lot of sense. If you are a bit familiar with the dopamine D2 receptor occupancy curves, you know that at a certain dosage, there will be a kind of a flattening of the curve, and you're not going to achieve anything more by increasing your dose, except nothing will happen besides side effects, of course. So I think I would call these futile attempts. The other reaction which we often have, and which you saw demonstrated in the vignette which I presented to you, is polypharmacy, that we add another drug to our primary drug in the hope that this will bring on some response. Again, I must disappoint you. Unfortunately, the research evidence is very, very weak for the efficacy of this. You probably are familiar with Dr. Correll from Northwell. He's done a huge meta-analysis. It's kind of a meta-analysis of meta-analyses. And he came with a conclusion that no single combination strategy can be recommended based on these data. He included 27 meta-analyses. So this was a huge data set. And of all possible combinations you can imagine, which have been tested in terms of polypharmacy versus monotherapy, and none of them really panned out to be sufficiently strong to be recommendable. So nilly-willy, we will have to confront the fact that clozapine has a good indication. It's the treatment-resistant schizophrenia and schizophrenia with severe suicidality, which I mentioned before. There are some off-label uses: assaultive behavior, substance abuse, polydipsia, hyponatremia, tardive dyskinesia. I want to mention those because occasionally you may run into a situation where you would need to use clozapine for that purpose. The burden has, of course, contributed to the low utilization rate. It's the hematological testing. It's also, I think, that treatment refractory schizophrenia is not, really fully recognized by many of us. We always hope that we may be discovering that the patient is actually a good responder, which often is, obviously not the case. Also, this other indication is not fully, appreciated, the suicidality. There's also an easy access to polypharmacy. That's probably another reason. And then finally, I think what sort of, I wouldn't say put the nail into the coffin, which would be a bit, not very fair, but the REM system places, I think, an added burden on the prescriber. And in my mind was probably, again, an excessive, sort of exercise by the FDA. Anyway, mortality in patients with schizophrenia, people are afraid that granulocytosis may kill my patient or some other side effect. In fact, if you look at a very excellent sort of database study by the Tihonen group from Finland, they looked at 66,881 patients in Finland versus the Finnish general population. And these patients were all using antipsychotics, and they looked at mortality, and they found actually that the lowest risk of mortality was associated with the clozapine. Even when they compared it to olanzapine, risperidone, and quetiapine, that advantage still persisted. So it's kind of, in a way, sort of anticlimactic to think that clozapine is actually protective of mortality when you compare it with antipsychotic treatment in general. There are, as I mentioned, some non-FDA indications for assaultive behavior. Currently, we are actually testing the clozapine anti-aggressive effect in a large trial, which we were just recently funded for, which is a 6-month outpatient study comparing clozapine to treatment as usual in patients with schizophrenia and who have a history of significant aggression. And we are just currently opening up the study for enrollment. What are some of the frequent side effects? I think we may have a few minutes to look at those. Let me sort of mention maybe the one which we are most concerned, which is really not, as you would expect, a granulocytosis, but constipation, and which can lead, if not attended to a small bowel obstruction. So it is important to use stool softeners, laxatives very, very early on. The other two sort of important side effects to keep in mind, myocarditis. It's rare, however, it does occur, and it's particularly at risk during the first 8 weeks. It is not easy to diagnose if you don't have some laboratory values. The best combination to monitor it would be to have troponin levels in the first weekly levels in the first 4 to 8 weeks combined with C-reactive protein. EKGs may be helpful, but are not probably the best predictors. Echocardiograms are not predictors for possible myocarditis risk. Seizures are well known, particularly at the high dose of clozapine. And then, of course, the classic neutropenia, which at this stage, with all the monitoring we do, is at a very, very low risk. What about if clozapine doesn't work, which these are the patients we call ultra-resistant schizophrenia patients. About 30 to 40% of patients on clozapine do not respond to clozapine. Are there augmentation approaches? They are not very strong, I must share with you. The studies are small. And the effect sizes are also not terribly impressive. So we have studies with Lamictal, Topamax, sodium valproate additions. These are GABAergic approaches. We have glutamatergic approaches. We have the most frequently used, which is anti-dopamine approaches, meaning that we are adding risperidone or olanzapine or another first generation drug, and that is very weak in terms of any effectiveness. Aripiprazole does have a bit of a data set available, but the effect size is small. ECT is something which we do at MPC quite frequently in patients who have not responded to clozapine, where we add it on, and that's sort of based on the Petridis study, where they did a randomized trial adding ECT to non-responders and rated them blindly. Compared to patients who continued on clozapine without ECT, and they found a clear, benefit of the ECT addition. So in summary, then, we covered quite a bit of, ground here. So let me just pick out sort of the most important issues I'm concerned about here. So when we are choosing an antipsychotic, stay with what worked in the past. Do not invent the wheel. Check the psyches, and I hope that everybody does have access to it. The response to antipsychotic treatment appears early on, and no response by 2 weeks is a very good predictor for later non or partial response. Long-acting injectable antipsychotics ensure a better treatment adherence. It's not ideal, but it's certainly better, and should be a standard of care early on. The evidence of antipsychotic polypharmacy is weak. Clozapine should be considered early for patients not responding to trials of at least 2 confirmed antipsychotics. And of course, the combination of medication with psychosocial treatments is essential for the final good outcome, in our patients. So that's in a fairly rapid sequence of some of the key issues, and I'm certainly ready for questions, Blake.
Thank you so much, Dr. Lindenmayer. We're really fortunate to have you share the talk with us. We covered quite a bit of ground. There are some questions that came through. The first one that came up was someone asking, from your experience, have you noticed any gender differences as part of a risk factor for NMS?
Yes, there is actually, and that has been documented. Young males are clearly at greater risk than females. We have seen it here, and it's also documented actually in the literature. And the question, of course, is, why would that be? That's really an even more important question. Why would men be at a greater risk? And I don't think we have a good answer to that. My somewhat uninformed answer would be that in general, female patients tend to do a little bit better with antipsychotic response, and with many other treatments as well. As we know, cognitively, females tend to be much better equipped. I have to say this to the chagrin of males. They have, I think, overall a better underlying neurobiology and respond better in general.
Thank you. The next question that came up was asking about transitioning from, and the use of Invega Trinza, that the current recommendations and guidelines were for 4 months of Invega Sustenna before switching to Trinza. And they were asking, is there any reason why patients can't be directly converted from oral Invega to Trinza?
I think this is an excellent question, because that is indeed the package insert and the recommendation to have the regular, monthly trials first. It has to do essentially with building up the plasma level of risperidone, which is really paliperidone, in fact, which will bring me to another issue I want to briefly mention. So it does take a while to get a steady state. And they looked, of course, at how many monthly Invega cycles would you need in order to have a steady state? And they essentially found it was somewhere between 2 and 3. And I think they were conservative and tried and said, look, you're going to need the full number. I think you can probably do it after 2. We have done it at times even after 1 cycle. We have not moved directly from oral Invega, which I think that would be probably premature because I don't think you have a steady state established with the oral Invega after 1 cycle.
One side.
Something else here, which does not seem to have, again, sort of gotten into the daily practice of many of us. Many of us do still prescribe risperidone twice a day, the oral risperidone. We see many patients coming to us with 2 milligrams twice a day. Pharmacologically, it doesn't actually make much sense because risperidone gets converted right away after absorption into paliperidone. 80% is essentially paliperidone and about 20% or even less is risperidone. And as we know, paliperidone does have a bit of a longer half-life as compared to risperidone. So it's a one-a-day drug. So to prescribe risperidone after 2 weeks on a twice-a-day basis, unless you have some psychological reason to do it, makes no sense. It should be done, once a day.
Thank you. One other long-acting injectable question related to your presentation and the vignette where you had put added Abilify Mantenna for the patient. Was it added before trying orals, or was the patient stabilized on oral medications first?
There we take a little bit of a shortcut. I know that the oral phase, keep in mind, for aripiprazole has a different reason than for paliperidone, and the cycling, the requirement for the depot cycles. It's basically a testing of the potential sensitivity to aripiprazole and to build up the plasma level. With aripiprazole, as you probably know, the half-life is exceedingly low. I mean, long, in other words, it's in your system for a long time. So you're building it up very rapidly, and you don't really need very much time on the oral. So you can skip the oral fairly rapidly and move on to your Mantenna.
Thank you. Next questions that came up. There was a question about what your concerns would be for NMS when treating psychotic patients for catatonia and restarting antipsychotics. How concerned are you for triggering NMS in that situation?
Actually, we have not been concerned. For one reason, that we haven't actually seen an NMS, I would say, for the last 10 years, probably. That was the last time I have seen a beginning NMS patient. So we don't see it that often, and that may have to do in part with the fact that the patients we receive, have already had quite a bit of antipsychotic exposure. So I could think that, somebody coming in to your acute inpatient unit who has been free of antipsychotic may be at a higher liability. So my answer would be differentiated depending where I would see the patient. If I had the patient in your unit, I might be more concerned. Patient is young, patient has not been exposed to antipsychotics, and is now in a catatonic stupor. And I'm not sure whether this could actually be, part of NMS syndrome. So I would be very careful. On the other hand, on our side, where we've had, patients who've been very much exposed, I'm much less concerned.
Thank you. We've got time for a few more questions. One that's been coming up has been about when you mentioned that Haldol is not preferable to be used for an emergent IM. Do you feel the same way? I guess the first was asking just specifically for your reasons, and second, do you feel the same way about Prolixin and Thorazine?
To some significant degree, yes. Look, think about it. Why do we have second generation antipsychotics? I think we can safely say they are slightly better in certain respects, not in all respects, obviously, because they do have this added 5-HT2A antagonism. And what does it do? Does it add to the antipsychotic effect? Probably not, although I don't think that the jury is in entirely. It does, however, protect to some degree for EPS significantly. And what I'm concerned about with the first generation drugs, that they're all high EPS conveyors. So Haldol is certainly a high EPS drug. Prolixin, trifluperazine, a little bit less. That's the reason, by the way, that's one of the reasons they used it in the Katie trial. But I would certainly be concerned. I do consider Haldol a little bit out of fashion because I think we have better, drugs than that. But old habits, seem to be lingering on quite a bit, and people are still using it. The other form, which is also being still used, is of course Haldol decanoate, which again, in my mind, we have better drugs now with our second generation, antipsychotics, and also with the depot antipsychotics. The drawback is, of course, the cost on one hand and the metabolics. And that's certainly something to consider. This is part of why I said in our choice of the antipsychotic will be underlying medical risk issues. So if we have a patient who is, struggling with, let's say, obesity, with significant diabetic risk factors, or is already diabetic, we may want to, look for other drugs than olanzapine or risperidone. And there are certainly other choices. We don't have to skip back to Haldol for that.
Thank you. I guess the next question is with the risk for tardive dyskinesia, what are your opinions on routine AIMS testing in the inpatient setting?
It's a very good question, actually. This sort of came up in a different context. As you probably know, we do have a new drug, which is highly effective for tardive dyskinesia. We have two, in fact. Valbenazine was the first one which came out. The question then was, and this discussion took place also with the manufacturer, who were sort of complaining that nobody was using it. Well, in part because tardive dyskinesia has really disappeared. And why has it disappeared? In large part because we are using second generation drugs, which have a much less liability for EPS and engendering, eventually tardive dyskinesia. It's still around, but I would say the frequency is much less. And maybe that's the reason the questioner is asking, does it make sense still to do an AIMS regularly on patients who are on antipsychotic? And I would say, yes, it does make sense because you still will be picking up here and there some tardive. It is not as dramatic anymore as we used to see it. We are talking about very subtle, and we are particularly interested in these very subtle tardive dyskinetic movements because often clinicians may miss them because they are not, really that overt. So I would say get good training in your AIMS so that you can differentiate, an acute EPS from a tardive EPS movement.
Thank you so much, Dr. Lindenmayer. We really appreciate the talk. There were many thank yous coming through in the questions as well. I think we'll have to stop there for questions. Having some technical difficulties.
Okay, I think thank you again. Thank you for doing the talk. It was wonderful. it was really refreshing to hear so many, the fact that, in a state hospital setting too, you guys are using so many of the newer medications. And I really, really think that it's, it's interesting that I think a lot of us still choose to use the older medications. And I hope that we can all sort of learn from this and change our practices a bit. So thank you again for taking the time. It was a wonderful talk. So welcome back, everybody. This is the virtual symposium at Mount Sinai Hospital, Clinical Challenges in Inpatient Psychiatry. We started off our morning with 2 wonderful talks, and we're going to continue the afternoon with this amazing panel. I'm going to introduce all our presenters today for the panel for this afternoon, and then they'll sort of start sharing their talks with us. I'll start with Dr. Serta. Dr. Serta has been at Thomas Jefferson and as a program director since 2007. He is actively practicing in the hospital, mainly in the emergency room, as well as general hospital CL services, and he's currently the chief of all acute services over there. He's also very active on the council of the Pennsylvania Psychiatric Society. He's been the chair or co-chair of all government relations committee most of the times. He's been on the board of the Pennsylvania Medical Society for over 10 years. He's been a part of he's currently the psychiatric representative to the PA Medical Specialty Leadership Cabinet. He is also a member of the board of the foundation of the Pennsylvania Medical Society and the board liaison to the Pennsylvania Physicians Health Program. He's been, I would like to point out that he was brought into this panel because he is also someone that trained Dr. Blake Rosenthal. So Blake, if you want to say a few words about Dr. Serta, I would, definitely, because he's been your mentor. So I would like to give you the honor to bring him on too.
Well, training with Dr. Serta was an absolute privilege in terms of learning how best to serve patients with really serious psychiatric illnesses and dealing with acute problems like suicidality and violence. He is informative in terms of shaping the way I think about care and trying to help this population, really helping anyone. So I'm so thankful that Dr. Serta took time from being in Hawaii to be with us today. And I'm really excited to hear what he has to share. Thank you, Rajvee.
Thank you, Blake. Welcome, Dr. Serta. I'd also like to introduce next Dr. John Rosell, who likes to go by Dr. Jack Rosell. Dr. Rosell actually has been also someone who's been working in the emergency mental health settings for about 30 years. He's been the medical director of the Resolve Crisis Services since 2010. His expertise, he has really been doing a lot of work in emergency psychiatry. He's kind of like the past president of the American Association for Emergency Psychiatry, which is a leading national organization dedicated to the improvement of compassionate, evidence-based care for people with psychiatric emergencies. As the medical director of these services, the crisis services, he has led a team of over 150 crisis professionals who deliver services every year to the residents of the Allegheny County through phone, mobile, walk-in, and overnight programs. He trains and consults with teams across UPMC and the country on projects related to violence and threat management, staff injury prevention, firearm injury prevention, crisis and emergency psychiatry. He's a distinguished fellow of the American Psychiatric Association, a recipient of the Exemplary Psychiatrist Award from the National Alliance of Mental Illness, and he was named as the Behavioral Healthcare Professional of the Year by CIT International. He is board certified in general, child, as well as forensic psychiatry, and he also has a bachelor's in biomedical ethics and MD from Brown. He has served as an incident commander for many, many mass shootings and has been involved in the behavioral health response to several mass casualty events. He regularly provides clinical and didactic training to medical students, residents, and fellows at the University of Pittsburgh School of Medicine, mentors students through the Center for Bioethics and Health Law, and co-teaches the mental health law at the School of Law. And he has been a CIT trainer for more than 10 years and provides training on violence and behavioral emergencies to a variety of regional and federal law enforcement professionals. This is why we invited him to speak with us today about the managing violence on inpatient units. And then, of course, we have our very own Dr. New. Dr. New is, as you all know, she is a program director, residency training director, as well as a vice chair for education in the Department of Psychiatry for the Mount Sinai Health System. She has a long-standing career as a funded principal investigator studying the neurobiology of borderline personality disorders. Her research focuses mainly on emotional dysregulation and emotional interoception abnormalities in borderline personality disorders, the symptom domains which underlie some of the most interpersonal difficulties encountered in this disorder. In addition, she also explores the individual differences in response to stress and trauma, focuses on how this relates to emotion regulation. She's been a teacher, a fantastic teacher, an amazing mentor to so many medical students, residents, postdoc fellows, as well as attendings. She was the director of medical student education until she rose to the position of residency training director and vice chair. She has won several awards for teaching and scholarship. And presently, I think she does an amazing job in helping and guiding so many of our residents and attendings in managing some of our very, very difficult cases. So I'm very happy to introduce all three of you. I think we're going to kick it off with Dr. Serta, starting to talk about helping manage suicidal behaviors and suicidal patients on inpatient units.
Great. Well, let me try to share my screen. Hopefully this will work this time. I'm afraid I had to switch from a Mac to a PC, so now I'm hoping this is coming through. Is this okay for everyone? All right, great. Yeah. Thanks. All right. Well, again, thanks so much. I can't thank Blake enough for getting me involved in this because I've learned so much from the presentation this morning. I'm looking forward to hearing Dr. Roselle speak again. I think the last time we spoke was in Harrisburg before a Senate committee looking at red flag rules and how to limit guns in Pennsylvania, which is a very gun-friendly state, let me tell you. And then Dr. New, of course, who's a force to be reckoned with at Advert. Let me go forth with my disclosures first. I am on the board of the APA currently, so I take Dr. Lindenmeyer's complaint about the guidelines seriously. I will try to bring that back to our group about long-acting injectables being used earlier. We are certainly doing that a lot on our unit as well as clozapine. I think everyone there is either on an LAI or clozapine, or else they've given us a big fight about it. I'm a member of the Consumer Satisfaction Team Board in Philadelphia. That's one of the things that was set up at the closure of Philadelphia State Hospital, looking at how to transition people from hospitals into the community, and that informs my talk just a little bit. And then I am a consultant to Independence Blue Cross, the largest insurer in Philadelphia, and some of the things that I think about when I'm thinking about suicide prevention is informed by that. I had a chance to look at a lot of different quotes in preparation for this talk. This is one of the ones that surprised me. Something that I think is helpful to keep in mind, that not everyone thinks about suicide the same way that we do. I think when you're trying to figure out how to feed 1 billion people, you may think differently. This is an old quote from Mao Zedong. There are different viewpoints when we're thinking about suicide, and some of our colleagues in other areas of medicine sometimes even, and some of our folks in the community sometimes think that basically if somebody's going to commit suicide, then let them do it. Especially some overworked nurses in the emergency room where I work, who will sometimes be very frustrated as they're trying to save one person as another person's trying to take themselves out. This is what I'm going to be talking about. I'm not going to spend too much time talking about statistics. We could spend days talking about suicide statistics with both their what's real, what isn't, how some of the flaws in the information is there. Then we'll talk specifically about what to do about the hospital care of people who are suicidal, how we manage it on an inpatient unit, how we specifically watch for suicide there. What do you do with the suicide attempt, especially with the suicide completion on an inpatient unit, which unfortunately I've had some experience with, when it's safe to discharge, and then how do you arrange for post-hospital care? Because of course, people can't stay in the hospital forever. I alluded earlier to the fact that we no longer have a state hospital in Philadelphia. And so it's extremely rare that anyone spends any extended period of time in the hospital system. And so everything depends on that transition back out. Again, another one, you'll see these slides popping up here and there, talking about different viewpoints about suicide. This is certainly not the kind of folks that we talk about as much. Schopenhauer, excellent philosopher, his ideas about suicide, inform a little bit of his time, where the thought was to get away from the church's view of suicide as a sin to more thinking about the humanism of we should be in control of our lives, without paying a lot of attention to the fact that sometimes we're not much in control of our lives because of a mental illness, which is what we're all trying to treat. Is that one of those, not sure if, just try to, there we go. This will serve for a lot of many slides that I could put up about suicide. It's just important to look at what's been happening with the rates per 100,000 over the last 20 years. Things were relatively stable until about 2006. Not great, but stable. And then things sort of took off. And between 2006 and 2018, there was either a 25 to 30% increase in the rate of suicide in this country. Why is unclear. There's lots of speculation about it. One nice thing is that it's beginning to tail off. I mean, there's been a lot of concern about how following the pandemic and the isolation that causes, we've kind of lost connection and maybe have increased the rates of suicide. That has not in fact happened. It was beginning to tail off prior to the pandemic, and it has continued to go down for the last 2 years. So we may hopefully have reached a peak, but why this is happening exactly is unclear. Suicide is hardly monolithic. As you can see here, men and women are vastly different in terms of suicide, as I think everyone knows. 4 times as many men as women. Although if we put up a slide for suicide attempts, it would flip around. The one issue that is buried in here is the fact that there's such a vast difference between suicide attempts and suicide completions across the country. Why is it 8 per 100,000 in New Jersey and 39 per 100,000 in Wyoming? I mean, they're not that different. I've been to both. They both have nice aspects to them, but why? I mean, I can tell you there are some of the things about the Mountain West has always had a much higher rate of suicide. It's more isolated. There's a lot more gun ownership out there. A lot more Protestants out there compared to Catholics and Jews in the East Coast and the West Coast. It's higher altitude. For some reason, there's an increased rate of suicide in higher altitudes. And then of course there's a lot more whites and American Indian and Alaska Natives in the West. So you can speculate forever, but just to say suicide is a problem. So let's figure out what we can do about it. One of the more famous folks who committed suicide, Vincent van Gogh. We can treat depression. We can try to treat depression. Van Gogh, as I think everyone knows, was treated multiple times. He is one of those folks who exemplifies the fact that the period after someone gets released from the hospital is something to pay attention to. He lasted 2 months after his last discharge from a hospital before he shot himself. At the age of 37, it's pretty amazing what he accomplished in such a short period of time. Whether or not his depression is one of the reasons why we have his fantastic works or not, people debate endlessly, but certainly sounds like it was a very unpleasant thing for him. So let's talk about hospitals. Since Van Gogh left San Remi Asylum back in the late 19th century, things have changed somewhat in hospitals. There has been a dramatic shift away from hospitalization, and hospitals have shifted from chronic care to more acute care. We need to try to make hospitals safe. And one of the things that has been a big factor in the lives of all of us who do inpatient work over the last several years has been this strong emphasis on trying to mitigate, to reduce the number of hospital suicides. There had been this figure quoted for years about 1,500 suicides per year in US hospitals. That figure, as it turns out, was vastly overstated. 49 to 70 per year is a very different number than 1,500 to 1,800 a year, which has been estimated, which is based on a guesstimate back in 1984 that was first posited in an article in 1984 that got picked up and repeated without any kind of careful scrutiny until this study that was published back in 2018. We are still paying the price for some of this and some of our efforts at ligature resistance in particular, but certainly our hospitals need to be safer. One of the problems with the focus on ligature resistance and other things is that one thing that's also clearly true is that the number of hospital beds has diminished dramatically. We've had a high of 384 beds per 100,000 in the 1950s, down to 11 beds per 100,000 currently. It's just a dramatic diminution. And one of the problems with ligature resistance has been making hospitals more acutely, more expensive. Again, why we do it is because suicide doesn't last, or I shouldn't say suicide doesn't last, but suicidality doesn't last. Ernest Hemingway, as I'm sure everyone here knows, had a very serious problem with depression, which came and went through the course of his life. Another example of someone who in the post-hospital period was at high risk. He committed suicide 2 days after his last discharge from his last hospital stay. It also illustrates that the very biological nature of this illness. His father, two of his siblings, his granddaughter all committed suicide, as well as the influence of addiction on suicide. Just to move on, this is the best slide I could find for folks who, when during the hospital stay, you have to be worried. Early on, again, this is from Denmark, where if you look carefully at the bottom here, you'll see these are months of hospitalization. We don't do such things in this country anymore. But it's early on, both in the hospital and then immediately after, they have to be most worried about. Transitions in particular seem to be a big problem with folks in terms of risk of suicide. And Kurt Cobain, another famous victim of suicide, who emphasizes the role that addiction plays. We don't often pay as much attention as we perhaps need to when people are first hospitalized, that they're no longer getting the substances in the community that have been keeping them together. And so paying attention to the sorts of things that that folks have been, like nicotine, opioids, alcohol or benzodiazepines, to try to smooth the transition into a different setting. Because again, the most dangerous time for people in terms of suicidality, suicide completion, is during the first couple of days of hospital stay. That's illustrated also by the fact that when we worry about suicides occurring in our setting, there are other settings too. Jails are probably the biggest place where there's so much room for improvement. It's disturbing. The rates of suicide in jails are just appalling, and the kinds of things that are done to try to prevent it are also appalling. In the Philadelphia system, in the jail system, prisoners are basically kept naked in a room by themselves. It's should not be that way. There are other things that can be done, but it's one of the things that hopefully we will be able to bring some of the things that we've been doing in our hospital units to other settings where people can be preserved. But how safe can we make it? Risk mitigation, I've already talked about. Again, my personal experience has been watching a number of units in the Philadelphia area close because of the need for risk mitigation and how expensive it is. On our unit, we spent $800,000 to put over-door sensors to pressure monitors so that if someone attempts suicide by hanging with a weight over the door, that was considered not enough. We had to get rid of all the standard doors in our patient bathrooms, replace them with the kind of foam things that I know most places have now put into place. They're not very private. Patients don't like them. It's one way that people try to get out of the hospital sooner because they don't feel any sense of privacy. We've had problems with hospital gowns. The strings on hospital gowns are very effective mechanism for ligatures. We're pretty good at keeping the hospital gowns or the paper gowns that we have on our units. But if someone goes off for a test somewhere else, they will sometimes come back. We had a problem with a patient using the strings that were on gowns that from a different unit that were not taken away from them as appropriately as they should be when they return to our unit. People share things. A lot of times folks don't think that they have any issues with their own safety, but forget that other people can get into their rooms and take things, and especially visitors. Visitors will often bring in things, not realizing that even though their individual family member is not at risk, that somebody else might be, and that's problematic. And the one thing that I didn't put up here, and it's an interesting omission on my part, is staff ratios. We need an adequate staff because a lot of what is the most useful thing in terms of keeping it safe is having adequate staff members and having trained staff members. We had a recent fiasco in a hospital in the Philadelphia area that had to fire a number of staff members because of people around doing checks were not checking to see if the person was actually breathing, and patients had died in the course of the night, and 12 hours later were discovered when the shift changed to have died through the night because even though they were checked, no one checked to make sure that they were actually breathing. You need adequate, well-trained staff. Again, another famous suicide, unfortunately, Marilyn Monroe, who reminds us that it can be fleeting. The thought of suicide can be there on Monday, and Wednesday you're laughing again. So one-to-one's probably the biggest way that we ensure that patients stay alive. How you do it exactly is important. Arm's length is always the best way. Although arm's length, knowing that you have other staff to call on if there's a problem. Most patients will not try to harm themselves when there's a one-to-one right at their side. But if in eyesight, maybe, and certainly if there's video monitoring. Video monitorings are only so good as someone is actually looking at the monitor. Well, I'll tell you that video monitoring are unfortunately a very useful thing to have after the fact. So it's almost like a quality improvement measure for your unit, having the video monitorings, not within the patient rooms. We are prohibited by our practice as well as state law from having monitors within patients' rooms except in seclusion rooms, but having a monitor there to review after the fact if there is an incident as to what we could have done better. I think everyone knows that having rounds, Q5s, Q15s, Q half-hour checks on the units are important, but they need to be done erratically. You can't routinely be doing it on the hour. They need to be done at 10-minute intervals, 20-minute intervals, and so on for Q15s, et cetera. Otherwise, patients will sense the pattern and change it. Same thing with change of shift on our unit. We have 12-hour shifts, and at the times of shift changes, some of our more sophisticated patients take that into consideration when they're going to engage in different activities. Certainly suicide is most likely to occur when a shift change is occurring. And then anytime that we do anything, both in deciding on length on a one-to-one, either putting it on or taking it off, is to document it. I think everyone does it. You make a change and you know why you're doing it, but you don't document why you're making the change. It's just so important. Another one of these many things that I discovered in looking at suicide quotes is Sue Rodriguez, who was a right to die advocate in Canada. She had petitioned to be allowed to have physician-assisted suicide after she developed ALS and had it got all the way up to the Supreme Court of Canada, which ultimately declared that it was unconstitutional, the prohibition against physician-assisted suicide. Canada has since put into place some of the more worrisome laws about permitting not just physician-assisted suicide, but actual euthanasia, which beginning in 2023 will lose the exclusion for mental illness. If you're suffering, you have a right to be asked to either with assistance of suicide or put to death. That was suspended for pain due to mental illness, but that is going to be going away, all in the interest of parity, as it turns out. It's a worrisome trend that I'm not sure where it's going to go. But in terms of screening for suicide, the Columbia Suicide Severity Rating Scale is kind of the what every surveyor that ever comes to our unit asks. Well, of course you do it, of course you do it, and they ask, of course we do it. It's not a very useful thing in many different ways. My biggest worry, and I should mention that most of my time is split between the emergency room and the inpatient unit. I spend lots and lots of time with the inpatient unit, or with the emergency room, looking at it. And like any screen, if a patient's not being honest with you, which is the biggest issue with our emergency room is people who want to be off the street because our social safety net is not really great in Philadelphia. They will not be honest with us about what they're doing, about how suicidal they are, and they will fake that. And so for that reason, it's not very useful. What's much more useful is, at least on the inpatient news, every day asking about suicidality and documenting what they're saying, and also our assessment as to whether or not we can believe them. In particular, especially in a teaching institution, monitoring what other people are saying in the record, making sure that the art therapists note about some of the disturbing drawings, or some of the things that were said in a community meeting, or a response to another patient's talk about suicide that was raised and documented by our activities therapist. You need to take a look. I mean, you really need to make sure that everyone on the team is sharing what's going on and hearing. We meet every day as a group, every morning, reviewing it, and hopefully that stuff comes off, but also look at what's being said in the record. And then my personal pet peeve is that we don't talk to families enough. Many times there's a concern about violating patients' rights when people are suicidal. I am less concerned about being sued for breach of privacy than I am about not having the information that I need to make sure that they're safe. So I think we need to really be careful that we communicate openly with family, and also hear from family what patients are saying to them. The Jonestown mass suicide versus Jonestown massacre was another aberration that I'm not going to get into too much here, but it was interesting that there are other views of suicide, as I point out. Let me talk about a particular patient that actually committed suicide on our unit long enough ago that I think I can talk about it without too much worry about breaching our peer protected veil. But a man who was admitted for ruminative thoughts about suicide, who started on antidepressants, was doing well, or so we thought, had set up outpatient care. He had only been in the hospital for about 10 days, which is an interesting thing, as our average length of stay on our unit is about 7 days. We all know that antidepressants take longer than that to work. I have been pushing that our average length of stay needs to go up, especially for people who are suicidal, because we really need the antidepressants to actually work rather than just be starting to work. Of interest was that the day that he was to be discharged, he was found hanging in his bathroom and ended up dying. And the effects on the unit, the effects on the staff, the effects on the other patients, his family, and of course, the tremendous sadness are still very much etched in my mind. What's interesting is that he did it the day of discharge. If he had left, if he had just waited just a little bit longer, he would have been home and none of this would have happened. There's a suspicion that he did this now so that he could be, there could be a significant lawsuit against the institution, since he had worked in corrections himself and knew what that could be. I'm running out of time, so I better get started going faster here. Sorry. But that when it happens, or hopefully it never will to any of you, but it may, first you need to take action to make sure the patient is, his life is preserved, that he both is prevented from making another attempt, and also that his life is saved. Reviewing lots and lots of case records of people who've committed suicide, having staff that are trained in CPR, knowing how to get crash carts to the unit, knowing where everything is, making sure that people know where the life-saving supplies are. The next point I make is that you have to sort of do everything at once. You have to let the family know. You have to make the liability carrier know. Who the patient's insurer is, hospital administration, all at the same time. So it helps to have in your mind, or somewhere on the unit, a tree of who to notify when and what the expectations are. Certainly have to manage staff morale. You have to make sure that documentation is done appropriately. I mean, everyone knows this case is a hot potato. People are afraid to document. If nothing else, make sure that if it's not documented in the official chart, that there is other records that are memos to risk management so that they can be peer protected, because people are worried about suit. They're worried about not saying things in the record that could get them into trouble. But a contemporaneous account is absolutely vital. And then of course we have to worry about our other patients. Having a mechanism, having a plan in place to how to get other patients away, how to have a discussion about what happened, taking into account the privacy of the patient that died and so on, because contagion can occur. Virginia Woolf, who was, again, getting ready to go back into the hospital for yet another time and didn't think that she could do it. And clearly had some signs of psychosis, as she alludes to. One of the saddest parts about working in a hospital setting where a suicide's occurred is the pain that other people feel. We want to make sure that we take care of ourselves, but also take care of our colleagues. So having a colleague who you can talk with about what happened. You want to, as much as you can, have discussions under a cloak of peer review, although I think most people are aware that peer review is something that is under court challenge constantly. We had an M&M grand rounds at our institution very recently, and the kind of boxes that we had to tick to satisfy our attorneys that it would be peer reviewed were just amazing. And her final comment to me was, and of course, a judge and a smart lawyer will get through this. But as much as you can, have a discussion under peer review, and then educate our staff about self-care. I mentioned Dr. Green, not that she was involved with a patient with suicide, although most emergency room docs are, but medicine is a demanding profession and can take a toll. You need to meet with the family after the event. I will say that that's one of the more difficult things that I've had to do. It's a requirement most of the time to notify if there are errors. In many states, Pennsylvania is one, there is an explicit prohibition against the plaintiffs using an apology as a bar from being an admission of guilt or blame. And ideally, it's done with another person present. Kay Redfield Jamison, famously bipolar, herself suicidal at times, psychologist on Hopkins faculty. Suicide is a tragedy. It's not a blot on anyone's name, either the individuals or the people caring for them usually. When's it safe to discharge? Of course, it's never absolutely safe. But we can't keep people in the hospital forever. You have to, at times, take the risk, balancing safety and return to functioning. I tell all my patients that, please be honest with me. I can't keep you alive unless we're working together, and you will die, and that would be sad, but there's only so much that I can do. So please be honest with me, and that's usually helpful. And then of course, involving family, letting them know about early warning signs and so on is really important. The lack of aftercare is a serious problem, both in our system and in others. COVID turned everything on its head with this problem of trying to discharge people to aftercare who had no stable home environment, didn't have phones. So it's been challenging. It's getting better now. The one thing about let every patient know, I do, that if they need to come back to the hospital, please come back to the emergency room at least. We try hard not to have that available to everyone who might want to set up the hospital as a way to get away from the problems of the world, but sometimes it's needed, and at least they can go back to the emergency room, we can see it again. Letting people know what the early warning signs are, especially sleep in particular, and then making everyone aware of the high risk period, trying to make sure the patient is not alone during that time to the extent possible. I put this in here because it's a famous Japanese author, famous in Japan, who to remind us that there are different cultural expectations of suicide. This gentleman in particular, who died in 1949 at the age of 40, made his first suicide attempt, and many serious ones over first suicide attempt at the age of 20. It also pointed out to me the Eurocentric nature of my education and the fact that there's a lot to be gained from other parts of the world. I'll just mention this one last case of a man who, the day after he was discharged, he came in with a very serious suicide attempt, stabbing pretty much everywhere, self-inflicted. He was discharged, and then the very next day was found by the state police who were coming to arrest him, dead in his garage with his car running. He had been involved in some activities that were going to cause him to be arrested. He was going to lose his pension because it was a public figure and was going to lose that pension. His suicide was mainly to preserve his pension. It was the one thing that he could do to try to make it up to his children, who he had not been a very good father to in his estimation. But making sure that he was dead before he got arrested made sure that his pension got preserved for them. So Stephen Hawking thinks that we should have a right to die. And then finally, and I'm sorry for running over, suicide can happen no matter what we do, but we need to do what we can. And that usually often means hospitalization. We can mitigate the risk in the hospital. It can't eliminate it completely. I tell all the families who want people in the hospital to keep them safe, we'll do what we can, and we'll do everything we can, but it can't be completely safe. We need to make our policies thoughtful and attainable, and then we have to follow them. And of course, document our decision making. We need to plan, and almost like a fire drill, what will happen if somebody attempts suicide here. And that the risk period really is probably greatest right after hospitalization, and we have to do that. And that I will stop. I'm sorry for running over.
All right. If I've done things properly,
Yes.
you should be seeing my cover slide. And if you want to see going over, let's see if I can stay on time. So I'm going to talk to you for about the next, hopefully slightly less than 30 minutes about workplace violence and acute psychiatry. I've no pharma or industry conflicts of interest for the past 15 years. I do lots of stuff around violence and violence prevention in lots of different settings for lots of different stakeholders, but nothing that's officially Acme related. And I'm not going to talk about anything commercial today. So I saw a question earlier in the Q&A section about slides. If I did things right, the management team should have a copy of my slides. And at the end of my slides is a list of some suggested readings. There's also a list of some really good resources related to something called Project Beta, which I'll explain in a moment. The literature on violence and psychiatry is fascinating and wonderful and deep and complex and nuanced. And whatever your attention span is, if it's something that you're interested in, take a look at those resources. And my contact information, my email and my Twitter handle will be on the last slide. And don't hesitate to reach out if I can help you pathfind your way through the interesting stuff that's out there. Right? I do want to highlight something from my own organization, the American Association for Emergency Psychiatry, which is something called Project Beta, Best Practices for Evaluation and Treatment of Agitation. This is a project that we started about a decade ago, and we had an initial half dozen articles in the Western Journal of Emergency Medicine, basically the California Emergency Medicine Doctors Professional Association. It's all open access. We followed up led by Ruth Gerson, who I think is local to in New York, and a number of other child psychiatry emergency folks talking about agitation in kids. And about 2 years ago, early in COVID, Ambrose Wong and a couple other colleagues did a really nice piece on agitation and how it relates to COVID, which, for a hot take that we dropped, 2 months into COVID, I think is actually held up pretty well. And all those WestGem articles are available open access, so very easy to access. And as a work in progress, as an opportunity to get involved, if any of you are so inclined, we're gearing up for sort of a broad update for the GAMA guidelines, right? All right, key points, right? So if you have to bail, if you get paged away, if you just say, I've been watching a seminar long enough, I'll come back for Dr. New when it's going to get better. These are the key points I want you to take away. Agitation's a psychiatric emergency. We need smart psychiatric people, psychiatrists, NPs, PA, psychologists. We need clinical experts to be managing these, right? If not, there's a substantial risk of elevated risks of injury to the people we care for as well as to our own staff. Also, prevention first, right? It's better to not have escalation than to de-escalate, but boy, verbal de-escalation is a really great tool. But also verbal de-escalation doesn't work for everything. And sometimes we've got to go hands-on, we've got to get coercive, but we don't want to leap to that if we can avoid it. And one of our best interventions here is that what we want to do is we want to disrupt the risk factors and we want to support and add the protective factors. We'll talk a little bit about that. And why are we talking about violence in general, right? So it's hard to heal for our patients. It's hard to care for us as professionals. It's hard to learn for our trainees. It's hard to teach for our leadership. It's hard to run, these high reliability organizations if we don't feel safe, if we are not safe, right? And there's a lot of stuff that goes into safety in a workplace, and especially in a healthcare workplace, right? So you got to understand, what's my role and what's my responsibility in keeping myself safe and monitoring the situation around me and helping those folks around me. What are the engineering or the structural things that are put in place to keep me safe? And what do I do to reduce the risk in the heat of the moment, right? It's not living in a hamster ball, right? It's not walking into an acute emergency psychiatric setting or inpatient setting and pretending that it's this magically safe place. But it's recognizing that we can and should have the right skills, knowledge, and resources to reasonably meet the risks in our workplace, right? We're not horticulturists growing orchids in a hothouse, right? We're acute care psychiatrists, and we have to find that dialectic, that balance between knowing that we work in a high-risk setting and doing everything we can to reasonably mitigate those risks without sacrificing the clinical missions that we're called to perform. Some of the best thinking that I've seen recently about management of agitation from Dr. Carmen Parker at Yale. And she talks about the importance of this compassionate, patient-centered approach to behavioral emergencies. This idea of centering and remembering that it's not just a clinical event, it's not just a medical or a psychiatric emergency, but it's a really sensitive and delicate situation that we need to effectively manage, right? That there may be some role for public safety or police or security or whatever term you use, but we really do have to continue to center healing as part of this process, right? It may be that, as all sorts of multidisciplinary interventions, it may be that our safety or security staff plays some role in this, but we still have to have it led by our clinical professionals. Someone is unmuted, maybe. So, all right, so for a breakdown, if you go to OSHA, there are 4 broad categories of workplace violence that apply to any setting, right? So the criminal outsider versus the employer facility, right? So this is, they're knocking over, the liquor store or the jitney driver or what have you, right? Or by the way, maybe as an employee in healthcare, as we walk from, the hospital to the hospital-owned parking lot, and someone robs us in the parking lot, that might be that criminal outsider versus an employee. We also have customer versus employee in our situation, a patient or sometimes a visitor. Don't forget about visitors versus us. We have employee versus employee. We call these, insider threats. Anecdotally, I haven't been able to confirm it with direct source materials, but I've heard it a few times, and it has a feel of truthiness to it. I'm told that the first campus shooting in the Americas was actually a duel after a faculty meeting at a university, which, some faculty meetings go better than others, right? There's a part of me that, I kind of get that one, right? And oh yeah, intimate partner violence versus employee, right? That nexus of danger that we bring with us into the workplace. But oh yeah, we're acute psychiatry. So we've taken our patients and we've sort of modified some things, right? We need to be thoughtful about facility attacks, which can take a lot of different forms. By the way, my own hospital, Western Psychiatric Hospital, recently recognized the 10-year anniversary of when an active shooter, someone who had never actually been to that building, that hospital before, came into our lobby and killed one of our staff and injured several others, right? It is a real risk, unfortunately. And as psychiatrists, we need to be concerned about other stuff, right? We've taken away a lot of rights and liberties from our patients. So, you know what, they need to be concerned about, are they going to be, you know, a target of a criminal outsider? And sometimes what we see this as, especially in a trauma bay, someone's been shot in the community, they come into the trauma bay, someone's coming in to finish off what they started. Patient on patient violence is a big one. Employee on patient violence. It's rare, but when it happens, it's ugly. And so we want to avoid that whenever we can. Intimate partner violence versus patient, which may not happen in our setting, but we've got to be really thoughtful about how, where, and why we're discharging someone. Now, by the way, for us as staff, the person who's most likely to injure us is a patient, right? But also note, and this can be a bit awkward, the person who's most likely to kill us is a paramour or former paramour who kills us in the workplace, right? So that's a lot to think about, right? As we sit here, some number of workers across the United States of America are going to be injured and injured seriously due to workplace violence, right? The most likely place where they are working is in healthcare, and it is not uniformly distributed, right? Healthcare professionals were about 4 times as likely to be seriously injured by violence than other workplace professionals. We have a rate that's comparable to law enforcement. And by the way, it's, you know, we shouldn't expect that the billing clerk at the dermatology office has the same risk as our inpatient teams. In fact, our inpatient techs probably have a rate of serious injury about 50 times other healthcare professionals, who are already about 4 times as likely as other professionals to be injured in the workplace. So the rates are substantial, and they're focused in our inpatient and ER settings. Well, what can we do, right? Part of this is we have to remember that even though we're psychiatrists, and we can and should think like psychiatrists, we have to remember that psychiatry isn't everything, and psychiatry won't fix everything, because most violence is not due to psychiatric illness or people living with psychiatric illness. Snapped our fingers, all the psychiatric illness that's out there sort of evaporates. Might have to rethink our departmental mission statements, and would hopefully see if we can still get a refund on our newly purchased DSM-5 TRs, but we'd still have most of the violence that's out there. Most people with mental illness, not violent, not towards themselves, not towards anyone else, not today, not tomorrow. Now, by the way, in acute care settings, we have a real bias, we have a real blind spot on this, because the people who get to us have been pre-filtered and already have a lot of risk, right? Most people with mental illness are far more likely to be a target of violence than to be a perpetrator. 25 times as likely to be a victim of a sex crime, 5 times as likely to be a murder victim. But we better get it right when there's an intersection. That's why inpatient psychiatry, that's where emergency psychiatry exists, right? Because sometimes there's an intersection, and we got to own that, right? And I think because we're really good at that recovery model, that biopsychosocial approach, we're also really good at thinking through all the risk factors and protective factors that aren't a diagnosis, that aren't a symptom, that really do help modify violence risk, right? So I think we still need to try, and we can still be quite good at it. And oh, by the way, we're also pretty good at understanding behavior, even when that behavior isn't the product of a psychiatric diagnosis. Well, a lot of times I get that question of, you know, okay, you know, what's the right training we need to have for our staff? Should we have metal detectors? You know, what kind of restraint bed should we have? Well, you know, right, there's a role for discussions around some of that, but maybe the most important thing we want to be thinking about is teamwork and communication. Hands down, without a doubt, these are our very best tools to reduce the risk of violence in healthcare. Over and over again, in med mal reviews and case reports and root cause analyses, M&Ms, you know, what does it come down to is, ooh, you know, something wasn't communicated the way we wanted, or the teamwork didn't work the way we wanted. And oh yeah, by the way, lots of times we know we go through these very bad adverse events and say, you know what, we did everything right. And the reality is our job is really tough. And sometimes we can do absolutely everything right and still get really sad outcomes. But, you know, as health professionals, and especially as team leaders, we've got a special duty and responsibility to our patients and to our teams to make sure that we're crafting a culture where this smart teamwork and communication is routine. And again, it's going to be our best tool to reduce violence. I like prevention, right? And I want to actually read you a poem that I saw, of all places, in the staff lounge in a hospital security department several years ago. I saw this about 12 years ago, actually. And again, this was just the staff lounge for the security folks, not even in a clinical area. And I'll read it to you. It says, "This may be a normal day at work for you, but it's a big day in my life. The look on your face and the tone in your voice can change my entire view of the world. Remember, I'm not usually this needy or scared. I am here because I trust you. Help me stay confident. I may look like I'm out of it, but I can hear your conversations. I'm not used to being naked around strangers. Keep that in mind. I'm impatient because I want to get the heck out of here. Nothing personal. I don't speak your language well. You're going to do what to my what? I may only be here for 4 days, but I'll remember you for the rest of my life. Your patients need your patience. What a beautiful call for compassion and dignity and respect, right? And if we do this right, if we do this consistently from the outset, we will prevent a lot of bad events, right? And we talked about apologizing for errors, realistic expectations, right? You know, hey, what time am I going to get transferred to the unit? I might say 6 hours and be thinking it should be an hour, but I'm going to I'm going to overestimate, knowing that lots of unexpected things happen in our workplace. So that, hey, if it's only 3 hours, great, we still look good, right? And oh yeah, at the end of the assessment, what else should I know about you and your experience with your illness? Or what else should I know about your loved one and their experience with their illness that will help them get better, right? Or what are we missing, or what should we be doing differently, right? When someone knows that we're having that conversation with them, it really helps take some of the heat out of that conversation. And it really helps us get more on that prevention side. All right, simple tactical question. It comes up a lot, like, where do I sit in relation to the patient? I heard a lot of people tell me in training, the staff member needs to be closest to the door. I heard a lot of other folks saying, let the patient be closest to the door. The theory being that if you have the staff member closest to the door and things go sideways, the staff member can get out real fast. But a lot of times the reason why the patients agitate is because they want to get out of there. And if you're between them and the door, well, that might hurt. And I've looked into this. I've gone to the medical library and looked stuff up and didn't get anywhere. And I talked to the medical librarian, and she kind of gave me a look like, you want to know about studies about what, right? She couldn't find anything. I've gone through the legal literature of lawsuits. I haven't found anything there. I don't know, right? It's not an easy thing for a randomized clinical trial. Maybe one strategy, which is sort of what I think of, it was like a equidistant, right? So I want to make sure that the patient and I both have relatively equal access to the door. And based on how that interaction goes, sort of depends on how I modify that configuration. Now, best case scenario, you have an eval room that has multiple doors, but my engineering team and our finance office keep telling me that's really expensive. So in the meantime, I sort of go for that equidistant approach. All right. Everybody's got a plan until they get punched in the face, right? Which I think was Mike Tyson's way of talking about, when you're under stress, we screw up, right? And biases and cognitive errors come out when we're under stress, right? It's really easy to go to a lecture hall and role play verbal de-escalation or to do it over a Zoom. It's a lot different when someone's got you cornered and they're screaming and the spittle's coming out and they're threatening to find and kill your children, right? When we're under stress, we don't always go to the right skill set. So what helps, right? Well, self-awareness, knowing that we have some limitations when we get under stress. And if someone's really agitated, you know what, it might have a real impact on us. Practice and experience, unfortunately. The more we've been through it, the more we're used to it. We've got a box in our trauma closet and we already sort of know what to do in that situation that can help out. Breathing, it sounds so simple, but the same stuff that we teach cops in use of force situations, like, take that centering breath like that. Like there's good physiologic data that moment's pause, maybe that quick huddle or that quick timeout before we begin an intervention in a patient safety perspective, that can make a real difference in how we approach it and to make sure that we are responsive and reasonable and not reactive. Remembering that our goal is to reduce the risk of injury to the patient and to our staff, and not to have the last word. And consultation, right? Before, after, whenever possible, bringing more people into that dialogue, and a healthy, high-functioning team can make a world of difference, right? And by the way, and I want to be really clear about this, part of that self-awareness, it's not just being aware that we can go in and we can be a little bit off because it's a stressful situation. We also have to be really mindful that when we talk about biases that increase under stress or threat, it's not just sort of those psychological cognitive biases. It's also those implicit biases, those racial biases, those gender biases, those religious biases, and those explicit biases can come out to play in some pretty toxic ways when we are under stress, or when someone else, our patient or their family member, is under stress. And so part of our assessment as we walk into a situation is, maybe am I over or under interpreting this person's acute or chronic risk for violence because of my biases, because of how they are alike me, how they are similar to me, or how they are different from me, right? There was a great article that came out just a few weeks ago in Health Affairs looking at electronic medical records and how the use of terms like agitated and aggressive were used. And it should not surprise anyone that they're disproportionately used in the charts of Black patients and people of color, right? We see that. We know that there's maybe some racial loading to those terms and those concepts that we have to be really thoughtful about, right? All right. Well, when Project Beta came out originally a decade ago, we put de-escalation in the center, right? Everything else sort of anchors back to de-escalation, whether it's part of our evaluation, the discussion with someone about medications. Why? It's safe. Sometimes we can de-escalate people that we would never in a gazillion years want to do a hands-on intervention to, right? I've seen 100-pound nurses go up to 6'4" firefighters on meth and verbally de-escalate them. And even though I saw them walking up thinking they're about to get squashed, I also remember thinking, if we go hands-on, we will lose. This person, is that strong and that big, right? It's recovery oriented, it's legally and ethically preferred, and it can be really, really effective. It just plain works. There's a wonderful article by Janet Richmond on verbal de-escalation as part of our original Project Beta toolkit. It's the most downloaded article in the history of the Western Journal of Emergency Medicine, which is a pretty big journal. It's a great article. Highly recommend taking half an hour to read it, right? It's this very simple, wonderful example of how to verbally de-escalate. I want to show you this video. You might have to turn your volume up just a little bit. He's reminding his little brother. He's staying with him. And it's not, I need you to calm down. I need you to breathe. It's like, no, let's do this together, right? And that's a big part of verbal de-escalation. It's not, you need to calm down, I'm going to verbally de-escalate you. It's, hey, you are upset about something and I want to find a way to figure out how to help you with this thing that you're upset about, right? To see if there's a way we can solve this together. How do I join with this person and align myself with them so that we can focus on the problem instead of, making it this sort of transactional or antagonistic interaction. Well, there are no randomized blinded trials for parachutes, but if you throw me out of an airplane, I will gladly take a parachute and will be happy not to be in the placebo group, right? In a recent meta-analysis looking at verbal de-escalation, it was, this is a hard thing to study. It's very much considered routine and expected in best practices. It has broad consensus acceptance, but it's also really hard to find a good randomized clinical trial that says, hey, this is a good thing, right? And so I think part of their conclusion is that, it can be a really important part of the toolkit, but also I think if we think it's the only part of the toolkit, someone's going to get pretty hurt by that, right? So how do we approach this? We want to make a cognitive pivot from, violence risk is high, medium, low, or Jack's at risk of violence is saying if then, right? So if risk factors A, B, and C are present, then risk will be high. If we disrupt those risk factors, risk will go down. If we add protective factors, risk will go down. if we lose, if we add protective factors, risk will go down. If we lose a protective factor, maybe employment, maybe a relationship, maybe even a pet, then guess what? Risk will go up. So we want to be thinking about the fact that everyone's got risk. We may not be very good at predicting what their likelihood of engaging in violence is, but if we can flag their modifiable risk and protective factors, then we can really move the dial on their risk. Now, in our world of psychiatry, some important things to think about. Psychosis. So it's not so much that I live with schizophrenia or schizoaffective or bipolar 1, blah, 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 but right here, right now, I'm sick enough that I'm having some of those active positive symptoms. As with everything else in psychiatry, comorbidity magnifies risk. And so if I have comorbid substance use or comorbid personality or comorbid conduct or history of conduct disorder, guess what? My risk is going to go up. If I'm not adherent with treatment, which might be I don't like your pills, but can also be I can't afford your pills. I know they help, but I can't afford them. Or, you know what, I can't do a tele appointment because every time I have a smartphone, someone steals it from me in the shelter, right? There's lots of reasons why people aren't able to take meds the way we thought they were. But that can be a big, big factor, obviously. And often we see elevated risks of violence early in the course of illness. So again, on a day-to-day basis, in the life of a person with schizophrenia, it's not that they live with the diagnosis of schizophrenia, but on any given day, they're having the active positive symptoms, hallucinations, delusions. And I get more concerned about paranoid or persecutory beliefs, but most of the meta-analyses really say that the mere fact that they're ill enough to have that level of symptoms is what should be concerning, right? So just something to think about there, right? And by the way, and again, and to emphasize, people with schizophrenia are far more likely to be a victim of violence than to be a perpetrator, right? And most of them do not become violent. But for the subset who are at risk with some of these risk factors, this is what we think about. Substance use. This is one of the big ones. And again, not that I live with alcohol use disorder or cocaine use disorder or anything else, but currently, recently, or frequently, I'm using to the point of intoxication or to the point of withdrawal. Maybe I get edgy and irritable with alcohol withdrawal. I probably won't get irritable with opioid withdrawal, but I'll have a craving. And if I have a craving, and you have a wallet, there's a way I can solve my problem with your wallet. And there's a few ways I can get your wallet, right? Personality stuff. I'm really, really looking forward to the next talk. But we always think about antisocial, which is the big one, but also narcissism, right? I'm entitled, I'm better than you. Maybe I have that sadistic streak that, the more I push you down, the higher I am. Borderline, especially in emergency work, we get so blinded, like borderline, we think suicide and self-injury. But the reality is that there's this big cluster of folks with borderline personality disorder who engage in self-injurious or suicidal and violent behavior, that when you take that group and add it to the folks who are just violent, you actually have maybe two or three times as many people in the violent group than in the purely self-injurious / suicidal group. Paranoid, I don't trust people, they're out to get me. Obsessive compulsive, I'm hypermoral and I am doing everything right and you are doing everything wrong. And oh yeah, right, we've got this thing called psychopathy, not really an official DSM diagnosis, but we know what it is. It's rare, but when you see it, it sort of takes the brakes off of people's willingness to stop the violent behavior or regulate the violent behavior. And querulousness, right, that bad combination of being really mistrustful and suspicious and being really good at sort of keeping track of all the ways that people have wronged us, right? I had a person who actually had file folders of all different coworkers. Each folder had a different name and it would have lists like, on March 10th, they didn't refill the coffee maker. On March 12th, they left a jam in the copier and blah, 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 right? Medical stuff, right? Hey, we're medical folks, right? So brain, pain, strain, remember these three things. Whenever we're approaching someone who's either currently agitated or at risk for violence, let's think as part of our decision-making process, is there something medical going on that I need to be looking at that's going to impact what their risk for violence or our intervention to reduce the risk for violence, right? That may mess things up or may increase the risk to them from an intervention, right? And again, anything that messes with the brain, including COVID, we're learning so much about sort of the neuroinflammation and prolonged neuropsychiatric sequelae of COVID infection. Anything that causes pain, which is both, I'm in a lot of pain, and so my frontal lobes that are usually good at problem solving are thinking, ow, 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 it hurts. Also, when I'm thinking I have 10 out of 10 pain, and you're looking at the standard order set, and your doctor ordered me 400 of ibuprofen, there's going to be some further discussion about what's really going to work for my pain, right? And anything that causes strife or stress between the patient or the family member and the treatment team. Not getting, the letter for the therapeutic support, emotional support, weasel, or, I'm shedding, can't you see I'm shedding particles because I was near someone who got a COVID vaccination? Doctor, why won't you help me? You're part of the system, aren't you, right? And then just sort of a quick final comment here about excited delirium. About 15 years ago, ASAP released a white paper, not a formal policy statement, but a white paper saying there's this thing called excited delirium, which is about severe agitation and sympathetic tone and, blah, 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 right? And it actually is accepted as a diagnosis by the National Association of Medical Examiners, but by nobody else, right? And when you look at the roots of this concept and the literature, it goes back to the pseudo-psychiatry of behaviors of enslaved people and the terrible legacy of people like Samuel Cartwright. Put bluntly, there's some pretty racist history to it. There's not a lot of science to it. And this diagnosis of excited delirium comes up a lot in people who are killed resisting arrest and in restraint-related deaths. About a year and a half ago, the American Psychiatric Association came out and said quite bluntly that it's not a diagnosis. The terminology is faulty. It doesn't really describe what's going on with the person, and said that term shouldn't be used until a clear set of diagnostic criteria are validated. And by the way, there was a great interview with Paul Applebaum in December of 2020. December 2020, talking about this on 60 Minutes, which is worth finding on Google, right? About a year ago, just less than a year ago, the American Medical Association got a little bit more blunt. They said, listen, this diagnosis and the way it gets applied, it's systemic racism that's dangerous and has deadly consequences for our Black and brown patients. Around the same time, we had a really great meta-analysis and systematic review by Stromer looking at restraint-related deaths and excited delirium, and said, listen, there's no evidence that supports excited delirium as a cause of death. What there is evidence is that this gets applied to people who die when they're being restrained dangerously or inappropriately. What I would emphasize is, as always, we have to screen and treat for underlying medical causes and medical factors that may increase the risk of our interventions, and recognize that restraint-related deaths are not about asphyxiation, all that is one element, but it's also about cardiac output. It's about metabolic acidosis. It's about lots of other physiologic factors that go into it that we absolutely have to be responsible for in our clinical approach and our interventions, right? So again, this is my email. This is the Twitter feed I share with Dr. Lila Solomon, a very wonderful forensic psychiatrist. And we talk about violence research and policy stuff and not about politics, because one of us is very wrong about their politics and we just don't know which one of us that is. Thank you so much. I look forward to the next presentation, the discussion coming up. So.
Okay, so.
Dr. New.
Okay, so first of all, I want to say before I share my screen that I'm delighted. I feel right at home with these two individuals from Pennsylvania. I went to college near Philadelphia at Swarthmore College, so that was not so far from Dr. Serta. And I for a year, ran the women's inpatient unit at Western Psychiatric Institute and Clinic. So I'm right at home on this panel. So let me share my screen and get started. I also found myself, let's see, can people see? Yep, okay. I also found myself thinking quite a lot about Dr. Charlotte's talk and thinking there are some similarities between what she said and the way I talk and think about borderline personality disorder, and we'll talk more about that. But I don't know if Dr. Rosenthal is still here, but I was imagining Dr. Rosenthal on a conga line and singing Yellow Brick Road to your patients, and it was a perfectly joyful moment. So okay, let me go forward. So I'm going to talk about what I say is a 21st century view of borderline personality disorder, thinking about violence, suicide, and inpatient work. And it is true to some degree that I'm a little bit on my soapbox about how to reconceptualize this disorder, but I will do so with a series of pieces of information and facts as we know them from the empirical literature, and then talk about the impact of this reconceptualization on how we think about borderline personality disorder treatment and in the emergency setting, in the inpatient setting, and how it generally an approach. Okay, so let's see. Now let's see if I can go forward without troubles. Okay, so here are my learning objectives. I don't have any conflict to identify. I have some grants from the NIH, but they are for training, and I'm not going to cite them in any of my work today. So to review the 21st century understanding of BPD, to consider stigma about this disorder in light of the high mortality and morbidity associated with this disorder, to consider the support and challenges to considering this as a legitimate psychiatric diagnosis, to consider the risk of harm to self and others in BPD, and to consider inpatient care of BPD. So why a 21st century? I think the main reason is to combat misconceptions and stigma. So what are some misconceptions? I mean, one of the more fundamental is that BPD is untreatable. Another misconception is that behavior in BPD is just attention seeking or manipulative. I must say that in my approach to patients, I give them the diagnosis. I give their family members the diagnosis. And if I hear the word, as I did recently from the mother of a young woman with BPD, that, oh, she's manipulative, that is a word I simply banish from my office. I don't use that word. Those with BPD do not complete suicide. That is a misconception. Having BPD is a choice. BPD does not occur in individuals under the age of 18, that it's rare, that bad parenting causes BPD, and that BPD afflicts only women. All of these are mistaken, as a matter of fact. So I start this with an email I received probably about 15 years ago from a woman who found my work on the internet, and she happened to be from Canada, which becomes relevant. She said, I've lived with symptoms of borderline for most of my teen years and all of my adult life. I'm 33. I began showing symptoms at around the age of 15, but did not enter treatment until I was 25. My parents never noticed a problem. I was just a moody, bad kid, not a teen who needed help. It was after several messed up relationships that I got help for myself. About the abolition of the distinction between axis 1 and 2, which was being contemplated at that point, she said, I think that the stigma surrounding borderline is bad enough, but having it on axis 1 would mean, in the US anyway, that more people might get treatment for it. I also think that if it was moved, on stickler for grammar, so I want to change that to were, but I'm using her exact words, there might be more research dollars invested into it, and certainly more education for families. My family has turned their back on me because they feel that I'm doing things on purpose and that I am manipulative. Perhaps if they understood that it has much more of a biologic cause, or that it was in the same category as other important illnesses like depression, maybe my family would have cared a bit more than they did before they gave up on me, is what she was implying. So, okay. So that was part of an early discussion. And of course, you know that to some degree, this movement, which this young woman was alluding to, prevailed, right? So axis 1 and 2 distinctions that was obliterated in the DSM-5. Personality disorders now appear alongside other serious mental illnesses in the section 2 of DSM-5. That creates a bit of strangeness because there are certain disorders that appear in more than one place, like schizotypal personality disorder appears both in the personality disorder spectrum section and also in the schizophrenia and psychotic disorder spectrum. So I personally believe it belongs more properly in the schizophrenia spectrum disorders. It runs in the family with people with schizophrenia and vice versa. But be that as it may, there are other things that I'm not going to go into a whole history of how we were unable to make appropriate changes in the diagnostic categories in personality disorders because of disagreement between psychologists and psychiatrists about how to construe these disorders. So DSM-4 was simply imported lock, stock, and barrel into DSM-5, but on next to as a major category of illness in section 2. There's a new general definition which really doesn't shed a lot of light. disorders of cognition, affectivity, interpersonal relationships, impulse control, and elevated pathological traits. I will focus on borderline personality disorder in this talk because I think it is the disorder we see most on an inpatient setting. There's a lot of interesting things to say about some of the other disorders in terms of violence, paranoid and narcissistic, but that was to some degree covered by Dr. Rosell. I'll talk a bit more about violence. I'll talk more about violence in borderline personality disorder itself. But the change about why was this change made from a 5-axis diagnostic nomenclature to this model of bringing personality disorders into the mainstream? And I think the answer was because it was understood that personality disorders are highly heritable, that they are predictable, they are definable by characteristics that can be clearly stratified into evidence-based, into well-documented assessment strategies. And so there was a whole history of its neurobiology that I think contributed to the understanding that these sets of disorders were real. So one of the things I often teach medical students, and it's true that psychiatric disorders, as you all know, are horribly stigmatized among medical illnesses, but borderline personality disorder is more highly stigmatized than any of the others, in my view. Why is that true? That may be true because of the doubts about the validity of the diagnosis, the complex nature of the symptoms. These are people who, unless you get to know somebody with borderline personality disorder a bit, you don't actually see the diagnosis. This is not something you can discern from across the room. The intellectual capacities are usually intact. School performance is not different from expected mid-parental performance. But what some of my patients would call the problem of apparent competency, where they don't have cognitive problems and they look normal, and yet they feel they can't function as they would hope to. And so that makes it hard to discern the diagnosis. Also, the relative refractoriness to treatment, which leaves mental health professionals to feel helpless. The disorder is characterized by the cardinal symptoms of anger and interpersonal disruptiveness, and that the relationship with their mental health providers is not immune from that problem. It's hard to form a therapeutic alliance with these patients, and it can be fraught with some complexity. But also, I think, because the name so poorly describes the nature of the disease. The name borderline personality disorder was actually coined here at Mount Sinai in 1938 by Adolf Stern. And it was meant to describe a disorder that was on the border between neurosis and psychosis. But since we typically don't use the word neurosis in our clinical nomenclature, it's widely used in the general population, but we don't use it. But we, of course, do use psychosis. It really is about the relationship among the elements of the Freudian model of the mind, the ego, the id, and the superego. And that is not really easily translatable into the medical literature. So it doesn't mean a lot to our patients. And I have to say that this is a disorder that's treated much more robustly in places where there's a single payer system because it costs a lot of money if it's left untreated into a healthcare system. But my colleagues in Germany, where they do treat this disorder a lot, one of my colleagues said to me, I don't know, Antonio, you Americans are so fussed about the name. Why are you so fussed about the name borderline? And, I said, well, what do you call it in Germany? I mean, what's the German name? And he said, we use borderline. And I said, well, okay, use the English word. I mean, maybe if we used the German word, my patients wouldn't ask me what on the border of what, but there is a plain language meaning to borderline, which is hard to explain to patients. So I do think that contributes to the stigma. So the problem with the stigma is it often precludes a frank discussion with the patient and family about prognosis, about the diagnosis. It deprives patients of information about their illness and about evidence-based treatments. It also has consequences on how patients are treated by mental health professionals. There was a qualitative study done of inpatient treatment of borderline personality disorder in the UK, And, I'm not great at sort of summarizing qualitative studies, but one of the most fundamental themes that was discerned from this, from focus groups, was that the patients felt that the staff members, as crystallized in this quote, always make you feel like you're taking up space, you're wasting a bed because you've got a personality disorder. So these are some of the things that underlie sort of why am I talking about the need for a 21st century understanding. So let's talk about what we do know about this disorder, some facts. So, is there an underlying construct to borderline personality disorder? Well, in doing large factor analyses, this is now a relatively old study by Chuck Stanislaw. There were these three domains: interpersonal disturbed relatedness, behavioral dysregulation, and affective dysregulation. But the factors showed a correlation with one another of 0.9 to 0.99, suggesting they were just so highly correlated that ultimately the paper argues that there is an underlying construct to what this disorder is. And I'll tell you what I think that is, but it really is, it's not that these people just happen to have, inherited a factor of disturbed relatedness and a factor of behavioral dysregulation and a factor of affective dysregulation. This disorder tends to cohere with a unifying underlying construct, which, there's been a lot of work on that, which I think is maybe too technical to get into because it relates to how the other personality disorders relate to this, but it is viewed as a uniform construct that can be described. And when I read the DSM criteria to my patients, they are often relieved to realize that there are people like themselves, that this is a recognizable illness. Otherwise, they've been completely baffled by their symptoms. Okay, so what do we know about the prevalence? BPD is present in about 2% of the general population, making it as prevalent as schizophrenia and bipolar disorder. Borderline patients are heavily represented in clinical populations and disproportionate users of mental health services and medical services more generally. These are people these are our medical frequent flyers as well as our psychiatric frequent flyers. DSM-5 states that borderline personality disorder is diagnosed predominantly about 75% in females, but the true ratio of men to women, well, unknown, but the results of community samples, when you use semi-structured interviewing, which is the gold standard for making these diagnoses, is a 1-to-1 ratio of men to women. And I actually think this is a gender bias that is difficult that actually deprives men of having proper treatment. I think men are more often then diagnosed with antisocial personality disorder when in fact they have borderline personality disorder. And that's important because the motivation for treatment is quite different. So the patients with borderline personality disorder under the proper context are much more treatable than antisocial patients. And so, So I think actually this is overdiagnosed. It's underdiagnosed in men, and that's why we see a gender bias. 10% of psychiatric outpatients and about 15 to 25% of psychiatric inpatients in the United States have borderline personality disorder. That's a publication in Lancet that actually I'm a co-author on. So what do we know about the longitudinal trajectory of this illness? So when it arises, it seems to arise in childhood. So a high-risk sample of girls who were ages 6 to 12 showed that when parents and teachers rated impulse control and aggression problems, they were fairly stable over that 6-year period. So it's not that, a kid, and there may be many reasons for this kind of thing, and that sample has not been followed up to know who will meet full criteria for borderline personality disorder, but these traits probably start fairly young. Parents report significantly more moodiness starting in the first year of life in borderline patients compared to their non-BPD SIBs, but and with poor self-soothing. I remember when I was running the inpatient service in Pittsburgh, I had a mother who said to me, well, so about her borderline daughter, I said, so when did you notice there was a problem? She said, well, I have 5 kids and they were all, only this one, got so angry she broke the crib. So I thought, okay, that seems like a pretty angry toddler or little girl. So I think we don't know the answer, because when you do a retrospective study scientifically, there's obviously the halo of the fact that you've identified the patient as the proband that may color the memory of what the parent says about their child. And there are not yet great prospective studies. The one I told you about, the 6 to 12-year-olds, is coming along, but there's not a lot of great prospective studies of children to know exactly when the full diagnosis emerges. But what we understand is that interpersonal difficulties manifest in elementary school. Impulsive aggression and self-destructive behaviors dominate in adolescence, and the full-blown diagnosis can be made clearly at puberty. But many people and this is important, because in places like Australia, another place where they have a single payer system, they have a referral base to a center called Origin that was originally developed by Pat McGorry for early diagnosis of prodromal psychosis, but actually so many people were referred, and they developed a second pathway for borderline youth. And so people can be referred there as young as age 11, and there's evidence that with their treatment called cognitive analytic therapy and case management, that you can bend the trajectory in a very positive way if you make the diagnosis in the teen years. The thing that's interesting is that that the full-blown diagnosis can be seen in puberty, but reassessed, patients fall in and out of being fully borderline or falling just sub-threshold. And that seems to be a pattern. Mary Zanarini has, from McLean Hospital, has followed patients over 20 years, and I'll show you some of her data, but it seems as if there's a fundamental illness that persists, but you can, whether they meet full criteria or BPD or not, varies depending on stress level, and I'll show you some of her data. So, and I will say that the way Mary describes her view of this disorder is that these are children who come out with sort of special needs children with emotional sensitivity and difficulty in affective regulation, and they need a special kind of, they need to be taught affect regulation management, and if so, they can be brought into not manifesting the behaviors of borderline personality disorder, but under stress will remanifest those behaviors. So there have been a number of twin studies of borderline personality disorder, and an early large study showed about heritability of about 0.42, which is a modest heritability. But a more recent study from a much larger twin study looking at a convergent latent factor analysis with latent factor together with derived from interviews and self-report showed a heritability of 0.67 for borderline personality disorder. So that's very high. That's higher than most, certainly much higher than depression. And it's, up there with bipolar disorder and schizophrenia. So in terms of heritability. So all studies of borderline personality disorder show a robust gene by environment interaction. And, it's a difficult thing because if you're borderline and you've inherited the genes of borderline personality disorder, it means you're very likely to have a borderline parent and may have a not the most stable childhood. So the synergy that most people are left with between their upbringing and their heritable genetic proclivities does leave them at high risk. So I should mention for a moment about the issue about trauma, because I think there has been this idea that borderline personality disorder is inevitably, if you meet a borderline patient, there must have been something traumatic that went on in their childhood. And I think this is a misconception. So there's some question of BPD as a form of PTSD, but a meta-analysis of 21 studies showed that particularly childhood sexual abuse has been implicated, showed a small effect size for the risk for borderline personality disorder. And the best studies that have been done of children with trauma show that, but studies really best done by Kathy Spatz-Whittam show that that when kids who've been reported for childhood abuse she's followed them longitudinally over a long period of time. And the most common outcome is astonishingly being okay, being resilient. But after that, the other common outcomes occur are substance use disorders, depression, PTSD, and borderline is higher in this population at risk who've been experienced sort of clearly demonstrated childhood abuse. But it is fairly far down the list of the adverse psychiatric illness, the psychological consequences of childhood trauma. And so, of patients with BPD, 20 to 40% don't report a history of child abuse. Conversely, 80% of individuals with a reported childhood abuse have no personality pathology. So the link between trauma and personality disorders is not as tight as people assume. That doesn't mean that our patients haven't been traumatized. Unfortunately, trauma is very common. Even sexual trauma is unfortunately very common. But it does mean, so when I hear this, it's not that I don't believe my patients, it's that it can't be the focus of treatment, because people hear this and think, okay, now that explains all the behavior, but that doesn't actually lend a hand to the patients to figure out how to move beyond that and have overcome their symptoms. So let me talk to you about some biomarkers. And I am a researcher in part, so I will describe, I could go on for like ever about biomarkers and will not do that. It is not, I promised Rajvee that this is not going to be a research talk. So what I'll tell you is that there's a developmental model. We did a study showing that that adolescents with borderline personality disorder have decreased fractional anisotropy in the inferior longitudinal fasciculus. So let me translate that into English. So fractional anisotropy is really a measure of the constraint on Brownian motion of water molecules in neurons, and basically it has been understood to be a measure of myelination. And this is why, we all say here that 25 people are not fully myelinated until they're 25, work based on Jay Geed's work. So in fact, so we did a study looking at adolescent borderlines, and they had impaired fractional anisotropy in these long fasciculi that connect the amygdala over here to the superior temporal sulcus over here, which is the major pathway to the frontal lobe for deliberate emotion regulation. And it showed that that was impaired, and that was not present in adult borderline patients. So there was a model that perhaps at a young age, there's something wrong with the wiring of the brain that connects the emotional limbic system, deep structures, to the more advanced parts of the brain that allow for emotion regulation. I should say that not only wanting to cite my own work, I'll cite Dr. Lichky's work showing that in adult borderline patients, this uncinate fasciculus, which forms a kind of fast pathway, remains impaired in its fractional anisotropy. So another biomarker is that borderline patients have incredibly high pain thresholds. So I put a picture of the kind of thermode that we've used, where you put that on the hand, and borderline patients will dial this up to the point of burning themselves. And so there's a lot that could be said about that. There's, the notion that perhaps one of the reasons borderline patients cut themselves is because you all know that when you cut yourself, at first it hurts and then it stops hurting as much. And that's because what is released by our bodies are enkephalins and endorphins, which attenuate pain. And there's an evolutionary adaptation to that, right? If you hurt yourself and you're running away from a bear, you have to hurt less so you can keep running. But the reality is that if you cut yourself and you don't feel the pain, it's not that aversive, and you've released endogenous opiates and elevated your mood. And so when you talk to borderline patients, they will describe that they cut themselves because it makes them feel better. Related to this would be the third point here, that there's decreased mu opiate receptors throughout the brain as measured by PET carfentanil. And this is a study done by Alan Prosson. And what that suggests is that there are heightened circulating opiates with patients who are cutting themselves, which downregulate the receptors, the mu opiate receptors in the brain. Another important biomarker that's been shown is that there's an impaired heart rate evoked potential in borderline patients. So what that means is that the neural imprimatur of our heart rate, which is in the anterior insula for most of us, is actually very poor. is very attenuated in borderline patients. And I will say, I told you what I thought. I was going to tell you what I thought was the core of what's wrong with borderline patients. And I'll say that I think it's this last point, which is that early on in my career, we decided to do something called affective startle, which was we put earphones on people and gave a loud sound blast in their ear, and we measured their startle response, their blink. And you can do that with an EMG of the orbicularis oculi, and you can get an objective measure of affective tone based on emotional probes. You measure the intensity of the blink is influenced by emotional signals. So we could measure that objectively borderline patients responded more to both negative and positive emotional probes, whether it was pictures or words. But what was surprising was that when we asked them to rate their own responses to those words and pictures, they had a more blunted response. So there was a real mismatch between their objectively measured emotional response and their subjective appraisal of their emotions, which comports with this idea that there's something wrong with the sensory system. They don't know what's going on in their bodies, and they're not good at knowing when they're hungry. They're not good at knowing when they're cold. They're not good at knowing when they're activated and angry. And so they basically this appeared to us when I saw this discrepancy between objectively measured responses and subjectively measured responses. I thought, okay, this reminds me of what I learned in my residency was alexithymia, difficulty appraising one's own emotions. So I decided to measure alexithymia in borderline personality disorder. And I will say that this was cool because it was quite a long time ago, I guess 10 years ago now. And the effect size is 24. And for those of you who know any statistics, that's an enormous effect size. So this is the Toronto alexithymia scale. So borderline patients are poor at identifying their emotions and describing their emotions. So they may be coming into a room furious, not aware that they're furious. The person responds to them as if they're furious, and then they are puzzled because they don't really know that that's what's going on. And in fact, I think what's been interesting is that, this is sort of laboratory work that I've been doing, but the evidence-based treatment for borderline personality disorder is entirely psychotherapy. And it is in fact grounded in the idea of, for example, using strategies of emotion regulation, but it starts with teaching people to pay attention to the physical symptoms. DBT, for example, starts with paying attention to the physical symptoms in one's own body to try to infer what one is feeling, because the automatic understanding of that doesn't happen right away. And in fact, sort of good psychiatric management of borderline personality disorder, which is a very bad term for what I'd say is the gold standard for treating this disorder. It's an eclectic treatment using elements of DBT developed by John Gunderson, and who developed the DSM-3 criteria for BPD and ran the Gunderson Center at McLean for a long time. John uses my work and the work of a few other, the small number of people who do work in the biology of this disorder to try to motivate people to do the evidence-based treatment, showing them their deficit in self-appraisal based on physical character, their understanding of their physical response, their poor interoception. And in showing them that, you take then toward your patient a pedagogical approach to teaching your patient. You stand side by side with your patient and you teach them what you understand is a deficit in their understanding of themselves. So that is kind of a more broad, that is a broad flash through to borderline personality disorder. And I want to give you some information about mortality, suicide, and violence and inpatient treatment. So what do we know about suicide? The completed suicide rate in BPD is about 10%, but 75% attempt suicide. So that there's a problem of a crying wolf problem here because it's very hard to discern when are they at the heightened risk. There's an elevated risk of these other things, physical illness, cigarette smoking, medical emergency room visits, motor vehicle accidents, I'll talk more about violence to others, occupational and psychosocial dysfunction. So this is an expensive disorder from a societal point of view to deal with. The thing I would say, because it's been all this sort of depressing information about this disorder, is that actually naturalistic longitudinal studies have shown that BPD with evidence-based treatment and it's naturalistic because it's not clear which evidence-based treatment, it's an uncontrolled sample, shows that BPD can be brought into remission. And recovery is when they no longer meet criteria for BPD at all. Remission is when they have markedly decreased symptoms. And that happens very, very fast, within 2 years with proper treatment in outpatient setting. 2 years doesn't seem fast for some disorders, but for borderline personality disorder, that's not too bad. Early mortality. Okay, so importantly, the Danish have been referred to before. They do amazing studies of people. They have population available data. So this is really a registry. This is about looking at all-cause mortality. I'm going to move this aside so I can actually see what I'm telling you. So basically in 1995, 97, 99, all through, you see that the number one would be the general population mortality controlled for age and sex. Borderline patients have a markedly elevated all-cause mortality for every year that was described. And so something happens that borderline patients die young, even in, okay, now why did that stop working? Okay. So how much of that is suicide? Well, in a 26-year follow-up study of 290 patients with borderline personality disorder and 72 with other personality disorders, borderline patients, 5.9% of BPD and 1.4% of people with other PDs died by suicide. And so in general, there was a heightened risk of suicide. And in fact, in a 26-year follow-up study, which is a lower rate. This is in the Netherlands, I believe. But there's also an overrepresentation of death by other causes. When we look, I'm citing other countries because we just don't have these data in the United States. In Sweden, predictors of completed suicide included a history of inpatient psychiatric care. And in fact, when you followed people who had been in inpatient care and looked at what are the diagnoses that was associated with completed suicide, borderline personality disorder is the highest, okay? The other disorders, substance use, psychotic disorders, bipolar disorder, no, borderline was the highest. And so this was sort of a startling find in 2005. And Mark Olfson showed that 2/3 of all suicide attempts in the US have borderline personality disorder diagnosis. So that suggests to me, so one could argue in that case that we're looking at suicide attempts as very different from suicide completions. How are we characterizing something that's an attempt? That's a strikingly high number. I'm not sure it's exactly right in the sense that how much of those suicide attempts had lethal intent. I don't know. But it has their higher risk of suicidal behavior than people with depression, for example. So in the emergency care of borderline patients, they're high utilizers of the PsychD. On average, 9% of the ER visits in one study. They engender frustration in the staff because they're difficult to deal with. They're often repeat visitors. I described that the crying wolf phenomenon is a problem, and people think, well, they cut themselves so many times, they've been here 6 times, with the idea that somehow that means that their risk is then lower for each time. But actually, the fact of having had non-suicidal self-injury or cutting or impulsive behavior actually heightens their risk of dying by suicide. So it's a very tough point because, yeah, they cut themselves and they come in and all in a stir, but it's not protective, and it doesn't mean they won't die by suicide. In trying to talk about what inpatient treatment can do, there's not great information about this. There was one Swiss study, which I thought, oh, great, we can actually understand this, showing that a 5-day hospitalization of BPD in a suicidal crisis led to decreased readmission. But what other treatment do we know? I'll put this up because I'll start by saying there are no FDA-approved drugs for this disorder, period. And in fact, most of my work with these patients is deprescribing, because what we know is that benzodiazepines tend to disinhibit patients, in much like alcohol, and increase impulsivity. Mood stabilizing agents have not been shown to be helpful and have a tremendous amount of side effects. Lamotrigine is probably the best tolerated, but the evidence for its use is poor. And SSRIs are helpful to some degree in the case of somebody who's depressed with borderline personality disorder and maybe slightly anxiolytic and have relatively fewer side effects. So they're more acceptable as a pharmacologic agent, but they have not really been shown to touch the disorder. And low-dose antipsychotic medication may augment the treatment refractory depression you see in these patients and may attenuate the impulsivity to some degree. But there are no really there's nothing that really touches this disorder from a pharmacologic point of view. That's part of what makes it hard for us doctors, because we like to know what we like to be able to help in a biological way. And we're really not there with borderline personality disorder. So they are high utilizers. Another study by Katie Comtois said, so they instituted a big study in Seattle, and she said, so the non-high utilizers, patients who are, some come in but not repeat. These are not the repeat offenders. These are not the people who keep coming back. 10% met criteria for BPD, whereas 4.5% on a clinical. These are research versus clinical criteria. They're slightly underdiagnosed clinically. High utilizers, though, were overwhelmed, were much more likely to be borderline. So borderline patients are our frequent flyers. They are really a substantial portion of our frequent flyers, I would say. I'm not going to, obviously substance use disorders as well. And they're just much more likely to be rehospitalized. That's what that study showed. I will show you. So the one point that I'll make, and I don't think it's so helpful to all of us, is that we don't have the opportunity to keep people for a long period of time with BPD. And there is this notion that somehow hospitalization won't help with BPD, but that is not really true. What is true, maybe the 5-day hospitalization in Switzerland, I'm not sure about that. That's one study, and it decreased the risk of readmission. I'm not sure where that gets us, but this is a great study showing from the Menninger Clinic where they followed people with borderline personality disorder over time, looking at the fall in the PHQ-9, the fall in the HUDAS, the fall in the anxiety scores, the improvement in disability scale, and the decrease in suicidality. And these time intervals, T0 to T2, are 14 days, okay? So most symptoms plateaued at T6 in terms of getting better. If you look at this, there's kind of a leveling out of all these curves, except the suicidality, I'll show you in a moment, but that's day 84. We don't really have the leeway to hospitalize people for 84 days, but maybe we should. Maybe we should have specialized treatment for this disorder where they can stay to 84 days. But the suicide, the Columbia Suicide Inventory does drop. And this is just a German study showing that adherent DBT for 3 months drops non-suicidal self-injury dramatically. So, there are a few studies, good studies of, short hospital stays for borderline personality disorder.
I'm
yep.
sorry, we're just over time, but I guess if you want
to
take a few more minutes, yeah, thank you.
I'll be almost done. Okay. In fact, I think I have 2 more slides. So I will say that there's a question. To argue that this disorder needs to be treated, one can say that in Germany, there's a huge waiting list and there's a lot of argument for more treatment. In Massachusetts, this disorder is now considered one that's covered. I want to go very quickly to the violence question and show you that that essentially borderline patients are at increased risk for interpersonal violence. These are not the people who are going to attack you on the street generally. The borderline patients are not at risk for random acts of violence, but they are much more likely to be engaged in interpersonal violence and domestic violence. And that holds true for men and for women. However, it's also true that borderline patients are far more likely, like other psychiatric patients, to be the victims of violence. So we need to be watchful for that as well. I'm not going to go through costs. This disorder is unbelievably costly. For in Europe, where they really pay attention, where they know the costs because they pay the costs. In this country, we don't really know anything about the costs, except that the best treatment in this country probably comes from the Gunderson Center, and that's $148,000 a year. Oh, sorry, for 3 months, forget a year. So I'm just going to go to say that I talked about good psychiatric management in the emergency room, and I will say that the part of why I focus so much on stigma is to reframe the way we talk about patients, and that is to engage in psychoeducation, to teach people about their disorder, to be authentic and active in your patients, with your patients, to give them hope of positive change through engagement in treatment, and to focus on educating them and the other people around them about how to de-escalate interpersonal relationships. And I would just say, this is, I think, my actual last slide, getting back to finding, okay, they have, so one of the techniques that works in inpatient, outpatient emergency room is validation, right? So if you tell a patient who's furious at you, I'm sorry that you're angry, I didn't mean to hurt your feelings. You've done two things. You've made a compassionate statement, and you have also given them a word to activate their emotion regulation strategies, which they themselves may not have understood that they were angry. So that's important. Don't try to reason with a patient who's in an emotional spin. Borderline patients get into these emotional spins, and I could show you endless brain imaging data about what happens to the brain, but it's not that important. But allow the patient to go into a low stimulation environment, and much like the patients with a developmental disorder, offer them food. When somebody's in an emotional state, it's really common for me. I keep things in my office, okay? And I, offer somebody a glass of orange juice. I offer somebody something. People if you're really operating in your most primitive aspects of your mind, you don't attack the person who's reaching out and feeding you. So I would say validation, giving people space. Don't reason with people until their spin is over, and acknowledge that the best role you can play is preventative by working collaboratively as an educator with your patient. Those are my tips, and I'll stop there.
That was wonderful. Thank you. I'm going to stop sharing your screen.
I'm going to stop sharing. How am I going to, let's see. Okay, stop share. Got it. Okay.
Thank you. I thought that was amazing. All three of you, that was a really, really wonderful hearing from all three of you. And I think, again, sort of going back to putting this panel together is really how interrelated all three of the topics we discussed today were, and even the clinical management, right? I think what you left at the end, Antonia, talking about validation, talking about compassion, and offering that, I think is like a common thread across all these three sort of major issues that we deal with. And I think most of us sort of think we know this, but I think in the moment when we are actually with a patient that's acting out in either one of those ways, it's hard to sometimes, put it all together. But also, again, similar to talking about what we were in the beginning of this, in the session, we were talking about the patients with developmental disabilities, and the same thing. How do we train the staff right at the front in just having that piece of compassion, keeping their own emotions in check? But again, I look forward to a wonderful discussion. So we have some questions here that I thought I can start that off with, and maybe you guys can sort of take it as you want to. Someone asked, what is your opinion on the emerging school of thought that questions the benefits of hospitalizing suicidal patients, especially on a locked unit without any opportunity to go outside? And I think this is something that we frequently struggle with, right? When you have patients in your clinic that you know them better as your outpatient providers, and you want to treat them, and you understand that maybe putting them in the hospital is not really going to change much, because when they come out, the environment is still pretty much going to be the same. So how do you, maybe any of you, Dr. Serta, if you want to take that, but.
Sure, I can start with that. I will say some of the most suicidal patients I've treated in the community. And it really just depends on what kind of support you can build there. I really look at the hospital as being a place where if there's nothing else, that's where we put the supports in place. But if there's family, especially, who are willing to do 24/7 with a young college student or medical student who don't want to have an inpatient hospital stay on their record, as long as they're willing to do it, absolutely. I with most of the people that I deal with, I try hard to focus on what can be done. I mean, we're not going, I met a guy very recently who is in a very difficult situation because he's in a marriage, has young children, got involved with a coworker, now feels like he's going to miss a chance to go out with the coworker and have a different life or honor his obligations and his kids. And he was really torn and could not decide and was going to kill himself. Drove his car into a bridge abutment, survived, and but still doesn't know what to do. We're not going to fix that. These are things that, but what we can do is we can talk, we can listen, we can empathize, and we can say, look, if you want to go on living, this is how we can help. And unfortunately, he had been trying to do everything on his own, and now having that intervention was very helpful. And but it's going to be touch and go, and trying to put into place outpatient support since he had no health insurance. It required a brief inpatient stay and then a transition to our resident clinic where he's going to get close supervision. But there's no be all end all to the hospital. I think that's one of the biggest issues that I find in dealing with family, my colleagues, and other areas of medicine. Hospitalization isn't a cure-all. I mean, it can only do what it can do. If there's an illness, we can treat it. If there's not, then we have to look elsewhere.
I think, my own take on it is the hospital can do a few things. It can provide respite for the family for a bit. It can give you an opportunity to search out outpatient treatment better. It can sometimes form a bit of a reset for patients when they've been sort of to jolt them into motivation to get more engaged in treatment. But I think, clearly, for borderline patients, clearly, but in general, engagement in their outpatient treatment is going to be the way to go. Of course, for what Dr. Rozelle does, if the patients are violent, you can also protect the public.
But again, I think we're very much on the same page here, right? We don't admit people just because there's suicidality or violence. We admit people because we think that admitting them is going to be helpful. And we know that because of the course of a lot of these illnesses, sometimes admitting someone is not only not helpful, but might even be harmful. Mm-hmm. And it's always an individualized assessment. And again, engaging with the family and explaining why we aren't admitting today can be really tricky. I will drop into the chat a wonderful article by a couple of my colleagues here at Western Psych about sort of how do you have that family conversation saying, hey, yes, you're right, your loved one really is at high risk. And as surprising as it seems, as paradoxical as it seems, putting them in the hospital actually might make it worse. So,
yeah.
Thank you for that. The other question we have is there a good assessment to determine violence or aggression levels for inpatient psychiatric clients?
A good one. I think probably the one that might have the best evidence is the DASA, which is the Dynamic Appraisal of Situational Aggression. It's got some really nice data in ER and inpatient settings, and both in sort of it's clinically useful in as much as, at the beginning of every shift or every day, the treatment team can say, okay, look, these are the 3 patients that are scoring the highest that we have to think most specifically about how are we going to modify the plan today. And also some really good data from nursing that says, basically, when administration came and said, you got to do something else on your rounding, at first we thought it was a pain in the butt, but now that we've done it for a little while, we actually find it's pretty easy to do, and we find it to be far more helpful than a hindrance. And again, because I'm nerdy, I'll drop a link in.
I agree.
What do you think of the Brosette?
I like it. I've used it. I actually used it. My last, sort of industry involvement was studying a medication for acute agitation, and we used the Brosette. I like it for sort of figuring out, okay, how agitated is this person now? How are they doing after we've had this intervention? When might we want to think about, getting them, out of the restraint or out of seclusion? But it's. I haven't found anything that said, oh, this is wonderful, that this will solve everything. So I wish I had. So.
I wish we all would have something like that for either suicidality or violence, right? Like magic wand that
Yeah, I actually, Dr. Serta, I'd love to hear more of your thoughts on the scissors, if I may.
I can't say that I'm familiar with it. I'm sorry.
No, I'm sorry, the Columbia Suicide Screening Scale.
I'm afraid that everyone who enters our hospital, and actually anyone goes to any of our outpatient clinics, is screened by it. It's been used in such a broad way, and it's the training that goes into the people doing the screening. It's often a tech down in the ER who's doing it, and people are put on either high, medium, or low without any real correlation with what we later find when we're consulted psychiatrically. That it's just such a waste of resources and an inappropriate use of resources. There are people who score really low because they want to get out of there, so they go out and kill themselves, that we fortunately can intervene and see. But the people who are put on elevated, put on one-to-one needlessly is just too much. It's a waste of resources.
In early days when I was at the VA, we had both the Columbia Suicide Screening Instrument, but also a follow-up with Barbara Stanley using these sort of suicide safety planning. And actually the most useful part for me, and this was in an outpatient setting, was sitting with the patient and talking with them about who were the people they were going to reach out to if they became suicidal. And this was not done by a tech, this was done by attending psychiatrists. And for me, sitting with my patients and saying, so who are you going to call in this case? And talking about the nature of those relationships, that was the only part that was useful to me. And I think it was good because it kind of hammered down that there was a piece of paper with both where we discussed the relationship, and we also had the paper with the telephone number on that they could tuck into their pocket. I thought that was useful. But, you know, apart from that, it's over-inclusive, right? Too many people are constantly suicidal, and, you know, it doesn't discriminate well enough. It's too sensitive and not specific enough, I thought.
I guess part of my problem with it also is having recently gone head-to-head with a reviewer from our state Department of Mental Health, who was insistent that whenever we changed a patient's inpatient level of observation, we needed another scissors, to use that term. I mean, it's like, well, how do you know that they can come off a one-to-one? Did you do another suicide rating scale? No, I talked to them. It's that the over-reliance on scales is troubling.
That is troubling. I know we as a system went through a whole, like a long year and a half worth of committee meeting and discussions, and created like our own version of taking scissors, and then adding like a whole biopsychosocial formulation attached to that based on positive and negative sort of risk factors, protective factors. And I think we still, I feel like, haven't really nailed it, you know. We keep tweaking with it because it's like, oh, is this high, moderate? If it's moderate, are we allowed to discharge somebody on a high risk? Because some patients probably still will always be high risk for both suicide and violence, but we can't permanently keep them in, like, you know. So I think this is going to be, I think, a problem that I don't know if we'll ever solve it.
You know, I do think one of the troubles that I think Dr. Serta was referring to is that part of the reason I think people end up getting hospitalized is because of the dearth of outpatient available resources. I mean, you know, for me personally, I'm often looking for, I mean, we are lucky that we have a partial hospital program here and that I can often access that. But even, you know, you know, people come to me and there aren't the resources for longer term care unless you have the proper insurance. And so, you know, I feel as if I'm talking often to colleagues at international meetings, and they have a single payer system, and they talk about, you know, their referrals are just clear. I mean, there are people obligated to take the patients. This is what it is. And actually, when I worked at the VA, the same thing was true. We had an opportunity. If we didn't have a bed at the VA Bronx, we went up to Castle Point. If we didn't have a space in our outpatient, we just had no option not to have a space in our outpatient program. Everybody was just covered. And I do feel like we spend a lot of energy seeking resources, even if we know what to do.
Without a doubt, ERs across the country are filled with psychiatric patients who are boarding waiting for an inpatient bed. And to some degree, part of this problem is because there's a lack of inpatient beds. But they didn't come into the ER because of the bed. They came into the ER because they didn't have the right, appropriate, available, accessible, destigmatized, affordable outpatient care. And yeah, do we need a few more inpatient beds? Yeah, we probably need a few. Do we need more ACT programs and IOPs and competent therapists who are comfortable working with a patient with borderline personality who comes in and says, yeah, like I'm a 6 out of 10 on the, risk, on my suicide scale today. And some people see that and say, and they don't actually have the full conversation. Like, actually, this is fantastic. So I'm doing like an 8. I sort of have this conversation with their trainees, it's like, well, maybe that 6 out of 10 might be the best they've done in a while. And that might be the person who lives at 0 out of 10, who's now at 3 out of 10, is the one that alarm bell should be going off on.
I supervised a triple board resident a few years ago who we received a patient in our OPD, who was a nurse who had a 10 out of 10 suicidality, made some very serious attempts. And I happened to have done the intake because at that time we had some chaos in our outpatient department. So I stepped over to do it. And the patient had a significant relationship with a man who'd been over time. So that was good. She had a very good education with the possibility of a good job. So I said to this resident, you're going to take her and I'll supervise you directly on the therapy. And we did therapy. She kept the patient for 2 years, and the patient went from 10 out of 10 progressively and slowly to sort of occasional fleeting suicidality. And by the end of the 2 years, the patient said, I'm done. I don't think I want to be transferred to another resident. She had a job. She had actually gotten engaged. And so, I said to this poor resident, you're going to be terrified because she's going to tell you that she wants to die every second of every time. And we're going to sit with that together and progressively work through. But that took a level of commitment and confidence on the part of the resident that I had her back, I guess. And, but that's what you want for every patient, to have that kind of level of care. And you can do that in a training clinic, but you can't do that everywhere.
And of course, the question is, why not? Why can't we do that everywhere? We can do it for knee replacement surgeries. We can do it for heart transplants. Why can't we do it for our illnesses? That's one of my biggest gripes.
I would agree with that. I personally have, I have to take some biologic thing because I can't take statins. So I personally was recently put on something that is an injectable. And I will tell you, going to the cardiologist, it's not a serious thing. This is all prevention. They call me and check how I felt. There's a gang of people caring for me, and I am not ill. I have a very modestly high cholesterol that I want to keep low so that I can have my grandchildren, whatever. And so, and yet I'm so envious of the fact that, I give myself one injectable and they call me every week to find out if I'm okay. I'm thinking, who is spending this time? Where are these people getting paid from? It's crazy. These are pharmacists and nurses and everybody, and I'm not even sick. It's very unfair.
The mental health parity issues that we've dealt with forever, I don't think they're going away, because clearly we don't make the same amount of money that cardiology makes, right?
Right, but why not is the problem. This is what, this is a policy and advocacy issue, which is a huge problem. And I don't know. I think, I do think the APA needs to get and is involved in this. I don't know. Any thoughts of how to have a broader voice?
It's how I spent my entire career, pretty much. Yeah. Getting involved with the medical society has been the most useful thing. Getting AMA involved to get parity finally passed back in 2008 was one of the things that I was the most proud of in my career. Because until we get the rest of medicine involved, saying, yes, this is really important, it doesn't really get there. And thinking that was going to do it was probably the most foolish thing I ever experienced. Since although parity is the law of the land and is law in many states, unless you have someone willing to sue the insurance companies.
There's no teeth.
Right. Yes, right. There's some things happening now where trying to get the Department of Labor to have, and I'm sorry, we're going way off topic here, but having the Department of Labor get data from insurance companies about how they're enforcing parity is probably the next way to go. And there's some legislation both in Washington and in different state houses. That's probably the next step, getting the Department of Labor involved.
So we need tort lawyers to help us. To
We
sue
do.
insurance companies. Okay, I'm married to one. I'll try to get
Wow,
involved.
what a way to end a conversation with doctors. We need more lawyers. All right, that's
Well,
wow.
I have one near and dear to my heart, so he will help us. He's on our team.
Well, I think we don't have many more questions coming in, and I think this was a good discussion and really some very interesting, talks about how to manage some of the day-to-day challenges that we face. Again, I really want to thank everybody for coming out of this panel, preparing these wonderful talks. I want to thank the participants. I hope that you guys had a fun day of, really good clinical pearls and discussions. And we will be sending out the recording, hopefully in a couple of weeks is what I've been told it takes. And make sure you go in and claim your CME credits for the time that you spent with us today. And we hope we can have more of these.
Thank you so much, Rajvee, for inviting me and for organizing this. I really appreciate it. And it's been wonderful to listen to the other people talking, and I learned a lot. So thank you.
Thank you.
Likewise. Thank you.
Everyone.
Thank you.
Thank you
Just
very
Bye
much.
all.
Thank you.
Bye.
We can let you go, Dr. Serta, back to enjoying Hawaii again.
Yeah, enjoy
I will.
Hawaii.
Yeah, the tie comes off
Amazing.
now.
We are so flattered that you are here with us. It's wonderful.
Thank you, everyone. Bye.
Bye-bye.